Good morning, delegates and faculty, and welcome you all on behalf of the organizing committee of SECON 2025 to this final day of SECON at Kolkata. This is Hall D, and we have a set of presentations this morning, two set of presentations of 6 each between 9 and 10 a.m. and 10:11 a.m. We have our esteemed judges right in front of us, Dr. Nisha Bhavani, Dr. Kaushik Sen, and Dr. Belinda George, each stalwarts from their part of the world. And to begin with, this is the thyroid session. This session is about thyroid, and we have 6 presentations. We may not be following the exact chronology of presentations depending on the arrival of our presenters, who should be here by now. But then anyone who comes in before the end of the session at 10 a.m. will be allowed to present. The judges have been explained how to score. You have that interactive tablet or a laptop to score. I think the names of the 6 presenters are there. Please do not forget to save and submit the score on each of the 5 parameters that you will be asked to rate. To begin with, we have our first presentation this morning, who happens to be Dr. Akriti Singh, and she'll be talking about the disappearing malignancy intrathyroidal water cell clear parathyroid adenoma, mimicking thyroid cancer with nodal metastasis. Dr. Akriti Singh.
A very good morning to all present here. I thank the organizing team, SECON, for giving me this wonderful opportunity to bring to you an intriguing case of the great thyroid masquerade, where we will, one by one, unmask the imposter. Let me take you to the beginning of it all, a case which was too classic to question. A 30-year-old woman presented with a neck swelling, clinically euthyroid. Examination revealed multiple thyroid nodules which were palpable with a firm 2 centimeter left cervical lymph node. The thyroid function test was done, which came out to be normal. What next? We proceeded to do a USG of the neck, which revealed multiple thyroid nodules. The right lobe lower pole showed a TIRADS 5 lesion, whereas the left lobe showed a TIRADS 3 lesion. There was a left cervical lymphadenopathy as well. We were all really alarmed and perplexed. Good morning. Today I will be presenting to you a rather intriguing case of the great thyroid masquerade, where we will one by one unmask the imposter. So let me take you to the beginning of it all, a case which was too classic to question. A 30-year-old woman presenting with a neck swelling, clinically euthyroid, examination revealing multiple thyroid nodules which were palpable with a firm 2 centimeter left cervical lymph node. The thyroid function test was normal. What next? We proceeded to do the USG of the thyroid of the neck, and we found that there is multiple thyroid nodules in both the lobe. The right lobe lower pole showed a TIRADS 5 lesion, whereas the left lobe showed a TIRADS 3 lesion, along with left cervical lymphadenopathy. Malignant, we were really alarmed. So we proceeded to do an FNAC, USG guided of the TIRADS 5 lesion, as well as the left cervical node, which showed a Bethesda 1 reaction. Again, we were really perplexed, whereas the left cervical nodes showed the presence of a thyroid tissue, suggestive of a metastatic CA, possibility of a primary in the thyroid, giving a differential of a lateral aberrant thyroid. We were confused whether it was malignant or not, so we decided to reconfirm the FNAC from another lab, which reiterated the same result. Now we were really perplexed and decided to end this confusion once and for all and go for a PET CT scan, which showed a hotspot hoax, an active metastatic disease involving the left cervical lymph nodes, level 3, 4, and 5 with mild FDG avid, as well as non-avid bilateral thyroid nodules, highly suspicious for a primary thyroid malignancy with METs. We came to a conclusion that this is likely malignant, and preoperatively, we went to do a serum calcium, phosphate, and IPTH levels, which came out to be normal. As per the decision of the thyroid surgeon, who decided to take no further risk, he proceeded to do a total thyroidectomy along with a central lymph node dissection, and the histopathology of the specimen was sent. The biopsy was what revealed the truth in the tissue, where we were expecting the total thyroidectomy specimen to show us a thyroid malignancy. There was an adenoma, That too of a clear cell variety, water clear cell kind of adenoma, which is one of the rarest rare kind of histology in endocrinology. And that too, not of the thyroid gland, but of the parathyroid gland. What about the thyroid tissue in the central and lateral nodes? They were aberrant thyroid tissue with reactive lymph nodes which were present. Here I am showing you the histology where parathyroid was a pretender with water clear cell kind of parathyroid adenoma, which is the rarest kind of histology in endocrinology. This suggested a parathyroid origin. We wanted to reconfirm this histopathology from another trusted lab of Kolkata, which reiterated the same diagnosis, suggesting parathyroid origin. Now we wanted a confirmation, so we decided to go for an immunohistochemistry stain. And the stain was what sung a story. The following markers were IHC positive, which is cytokeratin 7, suggesting that it is either a thyroid or a parathyroid origin, and ruling out a lymphoma. GATA3 positivity, which helped to rule in a parathyroid origin, as GATA3 is a parathyroid transcription factor. PAX8, which helped us to rule in a urothelial origin, parathyroid origin, and a thyroid origin, because we want to rule out clear cell metastasis from urothelial cancer, which is notorious for causing water clear cell CA. Chromogranin A, which helped to rule in a neuroendocrine paraganglionoma or an MTC, but rule out a follicular and a papillary thyroid CA. IHC negative stains were synaptophysin, which ruled out paraganglionoma, neuroendocrine tumor, and MTC. Carbonic anhydrase 9 and CD10 negativity, ruling out a urothelial renal CA, and finally our thyroglobulin and TTF1, which helped to rule out a thyroid origin. So this confirmed that the tissue was indeed of a parathyroid origin. The final act, the masquerade unmasked. It was an intrathyroidal water clear cell adenoma of the parathyroid gland, which was non-functional, as serum calcium, IPTH, and phosphate were normal. TFT was normal, and there was ectopic thyroid tissue with reactive lymph nodes. What is the lesson that we learned from the imposter? That when typical imaging and cytological features suggest a thyroid malignancy with a nodal metastasis, clinicians and pathologists together must remain vigilant about such rare diagnostic mimics to prevent overtreatment and ensure that there is a proper appropriate management given. We did a systematic review of literature which showed us that there are only 15 such cases of functional water clear cell parathyroid adenoma reported in the worldwide, and out of this only 4 intrathyroidal functional water clear cell parathyroid adenoma have been reported. This case, to the best of our knowledge, could be the first documented case of a non-functional intrathyroidal water clear cell parathyroid adenoma from India. Sometimes the wolf wears the sheep's clothing of carcinoma, but the bleat is parathyroid. I will like to end by saying that always keep the imposters in mind or risk reading the mask, not the truth. Thank you so much for your kind attention.
Good presentation. Thank you.
Thank you, ma'am.
What is the difference between water clear cell adenoma and clear cell adenoma?
Ma'am, clear cell comprises whenever the histology tissue is made up of glycogen or lipid, that is something which gives the clear to this, it makes the cell clear. So we differentiate it by putting different kinds of stain like pass positive, diastase sensitive, so the tissue is glycogen. If we put oil red O stain, the tissue is lipid. A water clear cell is of when there is much more component of lipid as compared to glycogen, although both are contributing to the clear cell. So it's a very rare variant of a clear cell as well. Clear cell itself is very rare kind of parathyroid adenoma histology, and water clear cell is even more rare.
And all the lymph nodes, all the tissue showed ectopic thyroid tissue, or only one? There were so many lymph nodes, no?
The lateral and the central compartment showed.
No, you said reactive lymph nodes and ectopic
There was,
thyroid
yes,
tissue
yes,
in
ma'am.
all the lymph nodes.
Yes, ma'am.
Ectopic tissue plus
No, ma'am. There was reactive lymph node along with ectopic tissue.
which showed the ectopic tissue.
There were some of the lymph nodes, some of the mass showed the ectopic thyroid tissue in the lateral and central compartment along with reactive lymph nodes. There were 4 and 25 reactive lymph nodes respectively.
Good presentation, Akriti.
Thank you, ma'am.
Can you tell me what percentage of patients will you expect parathyroid to be intrathyroidal?
Ma'am,
generally?
around 1 to 3% only have been reported in the world.
Good. So what is the clinical implication of that?
Ma'am, it implies that probably it was during the embryological descent of the parathyroid and the thyroid gland. There was some part of parathyroid gland while descending, it remained in the entrapped in the thyroid annulus. So,
So what is a clinical, like how does it matter to us whether the parathyroid is inside the thyroid?
because it presented in the guise of a thyroid CA with the mets, and we went on to do some over treatment to be on the safe side. We removed the entire thyroid gland without even checking where the thyroid tissue actually was. So in that way it implies, and it was an ectopic tissue which was present inside the thyroid gland.
Can you tell me the classic ultrasound features of parathyroid adenoma?
Um, they are generally hypoechoic in nature, and they are well circumscribed generally, uh, and uh, um, and they are normally they are functional. Here this was non-functional in nature, and there is no central vascularity. Generally there is a peripheral vascularity. Generally they are benign, and generally we do not find microcalcifications in them, rather macrocalcifications.
Okay, thank you.
Thank you, nice presentation.
Thank you so much, sir.
Thank you, Dr. Akriti. We move on to the next presentation in this series of thyroid presentations this morning. And our next presentation will be by Dr. Subramaniam Kannan, who will be presenting on thyroid tumor score, multimodal AI-driven approach combining ultrasound and molecular cytology images for classification of thyroid nodules.
I'm sorry, I'm not Subramaniam Kannan, I'm Dr. Samsam Sami. I'm his student.
Yeah. Yes, yes, yes. The presentation is from the same place.
Okay.
Right.
Thank you. Good morning, all. This study focuses on developing thyroid tumor score, combining multimodal data using artificial intelligence. Everybody knows about the problem statement. The current standard of care fails in diagnosing indeterminate nodules. There are 40% above indeterminate nodules are there. In that 60% came as benign, which may not needed surgery. Our research question is, can we improve ultrasound guided FNAC? We hypothesized that a data-driven approach combining radiology and a molecular marker to a cytology, can we improve the ultrasound guided FNAC to classify it into benign and malignant? So the first step was to select the marker which needed for a thyroid cytology. We did a systematic review and meta-analysis. We identified 4 markers. This is published in Endocrine Pathology 2022. And this marker we validated in tissues. Around 300 thyroid tissues was validated. And we got a sensitivity and specificity above 85% for differentiating benign and malignant nodule. The markers were focusing on glycosylation pattern. Glycosylation is it's a normal physiological process that happens when a normal cells matures. It becomes aberrant when it has become a cancer, and that pattern will be different in a different cancer. This marker we taken it a prospective validation in 3 multi-centers and supported by ESI grant also, and validated in a 700 nodules. So the samples which remains after standard of care were given in a SurePath solution, which is a cell preservative. The smears are prepared and the markers were added and taken the images using a fluorescent microscope. So we have a data of fluorescent microscopic image and ultrasound images. Coming to the ultrasound images was labeled by Dr. Subramaniam Kannan for the nodules, and we given to an AI called UNET, which segment the nodule out from the ultrasound image. We got above 80% IOU or accuracy to differentiating the nodule from the surrounding area. So this is an example of that, a video which shows that it's segmenting the nodule when it's scanning the ultrasound thyroid. Once it's segmented out, it has to be classified into benign and malignant. So we given benign when if it is a Bethesda 2 or histologically diagnosed benign, malignant if Bethesda 5, 6 or histologically malignant. And we classified with above 80% sensitivity and specificity for benign and malignant with a high specificity. So this is an example of Bethesda 4 case, which is a follicular nodular disease. It is diagnosed as benign lesions. And here this is a Bethesda 3 PTC which segmented the nodule, and it is classified as suspicious for a benign with a 99% confidence interval. Then come to the cytology. The cytology, we added 2 markers. This is a cytology microscopic images of Bethesda 2 to Bethesda 6, which is histologically confirmed by benign and malignant. The expression increased as the disease progresses. And the first step we have taken is segment the clusters and cells out using an artificial neural network. So we get the clusters and cells out. Okay, and then classified it as a benign and malignant. We got almost 79% sensitivity and 77% specificity. So what we have done is, we got an ultrasound image, we have a molecular cytology image, segmented out and classified with 80% accuracy. What was the data science problem here? It is actually when we take a USG image, it has a benign component and a malignant component. Same like a cluster also. If you take a malignant patient's cluster, there is a benign cluster and malignant cluster is also there. But we trained everything as a malignant. So that is called noisy label. And the second one is the dark data. Once we segmented out, above 3 cells, we taken it for the classification. If the cluster contained 3 cells, we needn't consider the single cells, blood cells also. So that 90% of data going become dark. So we taken another method called weakly supervised attention model. This model, the features were extracted from the backs of cells, clusters of USG of all the data from a patient, and it given to an attention model, and the attention model give a score, a high attention score and a low attention score for each images, and then it will give a classification. If there is an error, it will update the attention model to improve the accuracy. So when we're combining ultrasound cytology, we got 8% improvement in the sensitivity and specificity. We got an overall sensitivity of 88% and specificity of 90%. And what we understood is, when we are taking a malignant case, the most important high attention areas were
very nice study. So this AI-driven tool that was developed by Dr. Kannan, means in hospital you are developed?
Yeah, we have a research wing, we have a data scientist. Actually, I am working in this project as a data scientist, and we developed these models for classification and segmentation.
And that is based on this 392 patients, or more than that?
So, ma'am, for segmentation, we have taken more number of patients actually, because it does not need to know whether it is a benign or malignant. For classification, the number is reduced to 390 because it has to be Bethesda 2 or Bethesda 5-6 or histologically confirmed benign and malignant. So Bethesda 3-4, which is not histologically confirmed, were not taken for the classification. So there is a dropout from 700 to 370.
Okay, and is that number enough for a
AI.
model?
So
AI model?
here AI we developed with a 20,000 images for a classification. I'm sure it's not enough. It has to improve by more variation, and it is a multicentric 3 centers, but still needed because the thyroid. What I am also learning. PTCs, there are significant variation in the histological pattern. So it has to be improved, adding more data of PTC and FTC also. Here FTC we had only 25 cases or 30 cases. It needs to be added more actually. Benign or more, malignant has to be improved, the sample size.
Thank you.
So very good study. And how much was the increase in sensitivity and specificity after you added the AI model?
It's 88%. Yes.
Both?
Both, yes. For USG, it was giving 82%. Cytology is giving 80%. It increased to 89% when we are combining the ultrasound and
Along with AI?
along the cytology and ultrasound with AI. That is also with AI only, but it's only single data points. Here it is multimodal data combining the imaging of cytology and ultrasound.
So eventually, if this has to come into clinical practice, how would we apply it?
First, it has to do a clinical trial, like a Thyroid trial. It has to do proper trial, and it could differentiate Bethesda 3, 4. That was our problem persist because 6 and 5 and 2 already has a gold standard. So it has to be validated in a Bethesda 3, 4 properly as a clinical trial.
And about the markers that you used,
Yes.
eventually in your study you didn't add any of those markers, right?
No, sir. Cytology is done with only these two markers, galactin-3 and WJ, VJ agglutinin lectin.
The Bethesda cytology
Yes.
along with these markers, or only markers?
Only markers. The cytology, we didn't take any pap smear. We taken the cells from a preservative and smeared it and added the antibodies to these two antibodies to that. That multiplex cytology only we taken it forward. Because the cytology, histologically, it shows higher accuracy for differentiating benign and malignant.
And you have left out the intermediate nodules?
No, ma'am. We have taken intermediate nodules also
All
for training and
markers you
test
have
tubes.
taken, but only your final classification based on these marker expression is divided into benign and malignant.
Yes, classification is only two categories, benign and malignant. We taken Bethesda 3, 4 and 2 and 5, 6 also. But Bethesda 3, 4, which is histologically confirmed benign and malignant only we considered.
So you only done this on intermediate nodules? That's
No.
what you're saying?
No, ma'am. It's taken in Bethesda. I'm sorry, I'm confusing. I done in from Bethesda 1, 2, 3, 4, 5, 6.
Okay.
Bethesda 1, if it's histologically confirmation is there, we taken it. Bethesda 3, 4, if histological confirmation is we taken. Bethesda 2, 5, 6, we taken. Whole entire data set is taken.
Okay, all right.
I'm sorry.
Thank you.
I'm sorry. Sorry. Thank you, sir.
On to the next presentation in this series of thyroid presentations, which is reversibility of pulmonary arterial hypertension in Graves' disease following anti-thyroid therapy by Dr. Pradosh Sahu. This is the 5th presentation, judges, for your reference in the series.
Very good morning to all. Today I am going to present this study. The title of my study is Reversibility of Pulmonary Arterial Hypertension in Graves' disease following antithyroid therapy. This was conducted in MKCG Medical College, Berhampur, Odisha. Before proceeding further, I want to disclose that this study was supported by Indian Thyroid Society and there is no conflict of interest among the authors. As we know, Graves' disease is often associated with cardiovascular complications such as increased heart rate, myocardial contractility, atrial fibrillation, and pulmonary arterial hypertension. According to various literature, the prevalence of PH in Graves' disease ranges from 15.4% to 54.5%. PH is linked to high cardiac output state, vascular changes, and vasoactive imbalance. Recently, NEDD9, a profibrotic protein, is being implicated in PH associated with the idiopathic connective tissue disorder associated and congenital heart disease associated PH. So we plan to study this because the data on the prevalence of PH in Graves' disease and its reversibility with antithyroid therapy remains inconsistent. Thyroid autoimmunity has been suggested as a factor in the development of Graves' disease associated PH, but its role remains unproven. And there is no studies have been assessed NEDD9 in Graves' disease related PH, despite investigation in idiopathic PH, CTD associated PH, and CST associated PH. The objective of this study was to evaluate the prevalence, reversibility, and predictors of PH in newly diagnosed Graves' disease to assess the role of thyroid autoimmunity in patients with newly diagnosed Graves' disease and PH, to assess the role of plasma NEDD9 in patients with newly diagnosed Graves' disease and PH. This was a prospective observational study conducted in Department of Endocrinology, MKCG, MCH between June 2023 to December 2024 in newly detected Graves' disease patients. The sample size was calculated to be 68. The inclusion criteria were newly diagnosed Graves' disease patients aged more than 18 years, and exclusion criteria were pre-existing cardiovascular disease, history of pulmonary thromboembolism or significant pulmonary disease, autoimmune connective tissue disorders, drugs that can affect pulmonary arterial pressure like endothelin receptor antagonists, prostaglandin analogs, and CCB, infection that can produce secondary pulmonary arterial hypertension like HIV, HCV infection, pregnancy, and lactation, non-malignancies that can affect plasma NADD9 level like carcinoma, breast, melanoma, etc., and no non-malignant conditions that can affect plasma NADD9 like CVA, polycystic kidney disease. So in this, after receiving the IEC approval, we have included newly diagnosed Graves' disease patients aged more than 18 years. The Graves' disease was diagnosed based on the signs and symptoms of hyperthyroidism with elevated teeth, FT3, FT4, suppressed TSH, and TRAP positivity. At baseline, we have taken history, we did physical examination, routine tests like CBC, RFT, LFT, viral markers. Along with that, we did TSH, FT3, FT4, TSH receptor antibody, anti-TP antibody, and plasma NADD9, and 2D echo at baseline. Based on the mean pulmonary arterial pressure level, if it was more than 20, we grouped them into pH group. All the patients, they were treated with the carmazole and followed as per protocols. And these patients, they are followed initially at 2 months of interval, then after 3 month at an interval of 3 months, they are followed up till achievement of euthyroidism. And repeat 2D echo, NADD9 TRAP anti-TP antibody, there we estimated these levels after achievement of euthyroidism. Coming to the results, total we screened for 141 patients. Out of that, 101 patients were included in the, we did 2D echo in these patients. Out of which 11 patients, they are excluded because we cannot measure the mean pulmonary arterial pressure because of absent TRZ. We diagnosed 39 patients as to having PH, and we followed up them. And at the end, after achieving euthyroidism, there were total 5 patients who remained still with elevated pH, and rest of the patient normalized. Because of the small sample size, we cannot make any statistical analysis among them. So we have divided them into those who are having more than equal to 10 mmHg and less than 10 mmHg, which consisted of 20 and 19 patients respectively. In our cohort of study, the prevalence of pH was found to be 43.3%, and between the baseline parameters like comparing the pH and non-pH group, heart rate, FT3, FT4, TRAB, anti-TP antibody level, they were higher in the pH group compared to non-pH group. And all the cardiac diameters, they were higher in the pH group compared to non-pH group. And this diagram showing the scatter plot diagram showing the correlation of mean pulmonary TSH receptor antibody and NADD9 level with mean pulmonary arterial pressure level, which showed that the TRAB level and TSH, this TRAB level was positively correlated with mean pulmonary arterial pressure in overall group as well as in pH group, whereas NADD9 level, they did not correlated with mean pulmonary arterial pressure. By applying multivariate logistic regression, we found that heart rate, TRAP, and this anti-TP antibody level, they predicted, they are the independent predictor of pH in Graves' disease patients. And after achieving euthyroidism, 87.2% of patients, the pH was normalized. And this table showing the baseline clinical parameters and delta change in parameters between those who achieved more than equal to 10 mm of Hg reduction in pulmonary arterial pressure compared to less than 10. The clinical parameters, they are almost similar. There was no statistical significance. But in biochemical parameters, the TSH level was slightly higher. The baseline TSH level was slightly higher in those achieved more than equal to 10 mm of Hg compared to less than 10. And the TRAB levels were also, they showed a significant decrease in those who achieved more than 10 mmHg reduction. And the cardiac parameters also, they reduced after treatments. And this delta change in TRAB level, it predicted more than 10 mmHg decrease in pH patients by applying this multivariate logistic regression. So pulmonary arterial hypertension is common, but reversible complication in Graves' disease with high rate of resolution following antithyroid therapy. Thyroid autoimmunity plays a significant role in development of pH in newly diagnosed patients with Graves' disease, and NADD9 has no role in presence or improvement of pH in newly diagnosed DD patients. Thank you.
Thank you, nice presentation. So
Thank
this, what is the gold standard for diagnosis of pulmonary artery hypertension? Is this mean pressure, is it the gold standard?
Ma'am, gold standard is right heart catheterism, ma'am.
Any other method? Because it's a hyper, the flow is increased, no, there?
Yes, ma'am.
So it's a high output state.
Ma'am.
So can it be a false thing because of that, and because it is correlated with the heart rate also, no, in your study?
Yes, ma'am.
So can it be a false finding, which is just because of the hemodynamic changes associated with the graves?
Yes, ma'am. This in the higher prevalence of pH is mostly attributed to the hyperdynamic circulation that we found in the Graves' disease patient, ma'am. It is just a functional phenomenon, ma'am.
Yeah. So I don't know whether you can call it as pH based on this alone. Okay. And what percentage of patients of your Graves were TRAP positive?
Ma'am, we have included all patients with TRAP positivity, ma'am. So
alone. And that TRAP came down in 3 months, you are telling?
They are decreased, ma'am. Not normalized, but they have decreased from the baseline, ma'am. There is decrease in TRAP level in those patients, ma'am.
All of the patients got euthyroid within a span of 3 months only?
No, ma'am. No, sir. The median duration was 4.5 months.
You have taken a calculation on the end of 3 months, right?
Yes. After achieving euthyroidism, we have given a time period of 3 months, sir. Then we have did the 2D echo. Again, repeated 2D echo, NADD9, TSH receptor antibody and anti-TP antibody.
And from where did you get the NADD9? Is it done in your own lab?
We have procured the kit from Aveva System Biology from San Diego, and in our institute we are doing so.
Could you tell us the clinical significance of this finding? Will it change our clinical practice?
Mostly this pH is this is highly prevalent in Graves' disease, and with treatment of Graves' disease, this pH can be reversed, ma'am.
All right, thank you.
Thank you.
Thank you, Dr. Pradosh, for that very innovative presentation. We now move on to the second presentation in the series for the judges' reference, which is HSA-MIR in 99AFP restoration suppresses oncogenic features in PTC through mTOR downregulation, to be presented by Ms. Chandni Kashyap. The second presentation in the series.
Good morning, respected judges, faculty members, and colleagues. I am Chandni, PhD scholar from PGIMR Chandigarh. I'm going to present my work entitled microRNA 99A5P restoration suppresses oncogenic feature in papillary thyroid carcinoma through mTOR downregulation. So let me begin by briefly introducing thyroid cancer. So thyroid cancer is the most common cancer of the endocrine tumor. Globally, it ranks 7th among all the cancer in terms of incidence and 24th in mortality. The overall burden, including incidence, mortality, and prevalence, is particularly high in Asian countries. So thyroid cancer is broadly classified into papillary, follicular, anaplastic, and medullary thyroid carcinoma. So papillary thyroid carcinoma is the most common, accounting for nearly about 70 to 80% of all thyroid cancer, with recurrence rate of about 20%. Though its mortality rate is relatively low, but its increasing incidence begs further investigation into the molecular basis of PTC. So one of the key players in cancer biology that we focus on in our study is microRNA. So microRNA are small non-coding RNA that regulate gene expression at the post-transcription level. It can act as oncogenic microRNA or tumor suppressor depending on the context. So in our study, we focused on microRNA 99A5P, whose role have been evaluated in several cancer, but its role in papillary thyroid carcinoma along with the gene it target was still unknown. So to address this, firstly, we selected 50 cases of papillary thyroid carcinoma by reviewing their HND stain section. And then we analyzed the expression of MIN99A in FFP tissue samples and PTC-derived cell line, that is MDA-T32. And we found the expression of MIN99A was found to be decreased in both FFP tissue samples and PTC cell line, and we validated our finding with TCGA dataset. And clinical correlation showed a significant association with risk of recurrence. Then we wanted to perform the functional analysis by restoring this microRNA expression in MDA-T32 cell line. So we transfected our cell line with MIR99A5P mimics as gain of function, is inhibitor as loss of function, and negative control mimics was used as a baseline. So after transfection, we found that the expression of this microRNA was significantly increased in MDA-T32 cell line. Then to see its impact, we performed the various cell culture assay. So growth rate, cell proliferation, and cell viability assay showed the reduced cell count in cells which was transfected with MIR99A5P. And cell migration assay also showed the cells where MIR99A restoration was done, so it has reduced cell migration ability. Also, clonogenic assay showed that cells transfected with MIR99A had fewer colonies and less clonogenic ability. Interestingly, the cell apoptosis assay showed that the cells in which MIR99A was transfected has increased cell death as compared to other after 48 and 72 hours of transfection. So all our findings suggested that this microRNA restoration could suppress the oncogenic feature in papillary thyroid carcinoma. Then when we wanted to explore that which molecular target was involved in this suppression, so we analyzed different bioinformatic tools for target gene prediction and found that mTOR as a key regulator, which was common among all the tools. And this string analysis also showed mTOR as a central hub interacting with several other proteins. Then we analyzed the expression of mTOR in FFP tissue samples and MDA-T32 cell line, and the expression was found to be increased. Also, clinico-pathological correlation showed significant association with risk of recurrence. So this is the heat map and scatter plot showing the inverse relationship between MIR99A and mTOR expression. Also, protein expression was also increased when evaluated via immunohistochemistry. So now we wanted to see that whether mTOR expression would affect when we in the cells where MIR99A was transfected. So and we observed that the mTOR expression was found to be significantly decreased in the cells where MIR99A transfection was done. So summarizing my overall findings, so in papillary thyroid carcinoma, the expression of MIR99A was found to be decreased and mTOR expression was found to be increased. But when we restored this microRNA expression, we found it as a tumor suppressor microRNA via down-regulating mTOR gene. So mTOR is involved in processes like angiogenesis, which help in tumor progression and tumor aggressiveness. Since mTOR is an FDA-approved drug target, so our findings or MIR99A5P regulating mTOR suggest a potential therapeutic axis in papillary thyroid carcinoma. Thank you so much.
Excellent study. Is this the first time that this is being shown, or there is already, what's the review of literature? This has been done previously in other places?
Ma'am, this microRNA 99A5P expression was evaluated in other cancer, but this is the first time that we have evaluated this expression in papillary thyroid carcinoma.
World over?
Sorry, ma'am?
World over, this is the first time it is being?
Yes, yes, ma'am. Nobody has ever explored its expression, particularly in papillary thyroid carcinoma.
Okay, and this is specific or it is non-specific? Like this, this microRNA is specific to papillary thyroid or other carcinomas also?
No, ma'am. It is not particularly specific to papillary thyroid carcinoma. Its expression have been evaluated in anaplastic also, and it was also found to be decreased, like its tumor suppressor microRNA in ATC also, as well as in other cancer. It was also found that its expression has was decreased in other cancers also.
Okay, thank you.
Yeah, I think it was a very good presentation.
Thank you, ma'am.
Why did you choose to study this specifically? Because you said it was never shown in any other study before.
Ye-
So why did you decide to study this now?
Ma'am, we have some preliminary data where we have performed NGS in our patient cohort, and we found a list of particular microRNA that was found to be downregulated. So we then validated this microRNA via QRT-PCR, and this particularly miR99F5P was found to be most downregulated in papillary thyroid carcinoma. That's why we picked this one.
Okay, good. So how will you take this forward?
Ma'am, since this is it is still in experimental state, it's promising, but I think it's still preliminary. So it need to be validated in larger cohort, and also in vivo analysis should be done. So I think I have read somewhere that this mimics have been delivered to the patients, but this have been stopped at the earlier stage due to some immune-related concerns. So I think they have used liposome-related technique where they coated these microRNA mimics with lipid, and so it protects in our blood samples. So, but I think this need to be done in the future. Thank you so much, ma'am.
Thank you, judges, and thank you, Ms. Chandni, for that wonderful presentation. We move on to the next presentation, which is serial number 6 for reference, which is effect of T3 supplementation on quality of life in biochemically euthyroid patients on levothyroxine by Dr. Don David. And may I also request if Dr. Mukesh Darshan, the first presenter for this session, is available in this hall to please identify himself to the crew. Dr. Don, please continue.
Good morning, everyone. Today my study is on the effect of T3 supplementation on quality of life in biochemically euthyroid patients on levothyroxine. It is a randomized crossover study. It is the first of its kind in India where T3 has been supplemented and a quality of life has been studied. It is supported by the academic grant of ESI 2024. So around 10 to 15% of the primary hypothyroid patients have persistent residual symptoms despite biochemical euthyroidism. So inadequate tissue T3 availability and genetic or autoimmune mechanisms might be the probable explanations. So we intend to study or evaluate the effect of T3 in the quality of life for already on stable levothyroxine therapy with residual symptoms. So the need was like a persistent symptoms despite biochemical euthyroidism, physiological limitations of LT4 monotherapy, which is causing a tissue level T3 deficiency, role of genetic and autoimmune factors like deiodinase 2 polymorphisms. There is an evidence gap in the Indian population and the patient related outcomes and the potential for personalized therapy. So there has been various trials till date. Only 2 trials have been shown a positive outcome on the T3 T4 combination therapy. Coming to the Indian scenario, there has been no RCT based on the T3 T4 combination therapy in Indian population, which provides with a significant knowledge gap. So we have devised to actually rectify all the previous drawbacks of the previous trials and fit into our scenario. So my aim was to assess any residual symptoms of hypothyroidism on levothyroxine supplementation by a validated questionnaire like Thyroid questionnaire and to evaluate the response of T3 supplementation in patients with persistent symptoms. So it was a prospective double-blinded randomized crossover study which was done on a period like around 6 months. Participants were allocated in 1:1 ratio with intervention and the control arm. And Thyroid questionnaire were assessed at baseline 3 months and 6 months, and statistical analysis was done with paired t-test and Pearson correlation. So inclusion included age 18 to 65, primary hypothyroidism on treatment, normal TSH on LT4 for more stable TSH for more than 6 months, with the persistent symptoms having a Thyroid questionnaire of more than score of 60, and excluded like severe comorbidities and pregnancy. Though the study protocol includes screening of around 350 patients with baseline estimation, block randomization was done, and the drug was dispensed, and follow-up was done for any adherence check, and crossover was done at a period of 3 months, and the end of the study was around 6 months, and it was analyzed for safety follow-up also. So this was the intervention arm, where we can see the unwrapped T3 bottle, which is available in India, where we did it like to be it similar to the placebo, so that confounding can be avoided. And we did the placebo in our pharmacy only, like which is similar to the T3 available in India. So enrollment included assessment for screening of 350 patients, randomization of 30 patients with allocation of T3 T4 combination in the intervention arm, and the T4 to placebo in the placebo arm, and crossed over at a period of 3 months, and completion of the study with analysis of 30 patients on T4 T3 and also on T4 with placebo. So the baseline characteristic was a mean age of 38.9 plus or minus 9.1 years, with predominant female, with all having a quality of life domain of more than 60 score, which was taken as the baseline score for the initiation of therapy. Coming to the results, we had a cohort of 30 patients where improvements didn't correlate with the thyroid hormone levels, but the quality of life scores, when it was analyzed, with the baseline score was around a mean of 722. After T4 to T3 combination therapy, it significantly reduced to 514, which is showing a better quality of life. Then was crossed over at 3 months to placebo therapy, which showed a 656 mean score, which is showing an again increase in symptoms. So this shows that there was an increase in the score after the placebo was initiated after the combination. So that signifies the T3 was having a help for the quality of life improvement. So this was the analysis in which hypothyroid symptoms were had the maximum reduction. Here we can see the hypothyroid symptoms having 63% reduction, with anxiety and depression around 30% reduction. And in the effect of placebo, it again increased the score to around 40, that is 50% increase after the placebo was initiated after the crossover. So the specific quality of life domain showed hypothyroid symptoms having a 63% improvement in the quality of life. And there was also a patient preference seen in around 63%, that is around 19 on the 30 patients. So my strengths were, it was the first RCT in Indian cohort with a double-blinded RCT with validated quality of life instrument Typro questionnaire. It was a crossover design which tried to significantly reduce the bias. Limitation was a small sample size. It was only 30 people could actually complete it. Discussion, it was combination therapy significantly improved the quality of life versus the T4 monotherapy. The quality of outcomes were more in tiredness, cognition, physical functioning, with 63% reduction in hypothyroidism, 36% in tiredness, and 28% in depression. So implication is like Typro score can be used as a threshold for considering combination therapy with a safety profile. And this is the data on the previous studies with our study, in which we could actually tick almost all the boxes which the previous studies had the drawback, like clinical status, quality of life, depressive symptoms, with a patient preference with a 24 weeks crossover. And DI2 polymorphism in Indian population, the recent study shows 63% increase. So routine testing could actually be recommended, but in an Indian scenario, whether to go for it, we still have to look upon a lot more studies. So concluding, T4, T3 combination therapy has a significant reduction in hypothyroid symptoms. To look for a precise medicine personalized approach, and futuristically, when a patient comes to us, we can assess like a baseline Typro score. If it's more than 60 with residual symptoms, we could actually consider a T3 trial for a period of 3 to 6 months. If possible, deiodinase 2 polymorphism also in subset of patients.
Good, Dr. Don. See, you said hypothyroid symptoms improved maximum. And what were the hypothyroid symptoms? All the symptoms were written separately.
No,
So
ma'am.
which were the symptoms you specifically told
No,
hypothyroid?
in the Thypro questionnaire, we have 13 domains, ma'am, out of which hypothyroid domain had symptoms which are specific for like how the patient is feeling in that domain. So it is around 11 points in each domain. So it is a Thypro score is 84 scores, 84 sub-segments is there, out of which we will take all patients who are having a score of more than 60.
Is this Thypro score validated in Indian population?
Yes, ma'am. Yes, ma'am. It has been validated by Watt et al. In an Indian population also, ma'am.
Okay. And then you haven't compared like Thypro 60, 50 and 40 and all, like beyond which you took just a cutoff of 60 just like that? Why
No,
did you choose 60?
because higher score for Thypro signifies lower quality of life. I included all patients who are having a more than
No,
60 score.
what is the sanctity of 60? Why it's not 65 or 55?
No, even in previous studies all over
based on previous
studies also it has been included.
And what happened to the T3 and the TSH after treatment?
After treatment, TSH is normalized, sir, ma'am. Like it was not suppressed compared to the previous studies. Like previous studies had a drawback of whether it is having a safety profile if it's going for a suppression and patient is having a hyperthyroid kind of scenario. So in our cohort, it was shown to have a normal TSH, not a suppression.
Okay, thank you.
Good study. Can you tell me how you randomized the patients?
We did a block randomization, ma'am. Like in 6, we had 30 patients, so we did it 6 block randomization at 5 subsets, so that everyone is equally randomized. So we did a block randomization of 6 sets of 5 into 6. So.
And in your results, you had shown pre-treatment, post
Yes, ma'am.
combination, and then going post-placebo, right?
Post-placebo. 3 months we crossed over.
Like the crossover, it's a total. So you're taking the first 3 months here and then.
First 3 months was the baseline was taken, and the first 3 months T4 T3 combination, ma'am.
Only for half, right?
Only for half. No, then that other patient who was in the placebo arm was shifted to T4.
So your results, it's combined all together.
All together, ma'am. All together.
Yeah, I presume all the patients were of primary hypothyroidism?
All were primary hypothyroidism with proven TSH more than 20.
Did you have any substrate stratification of the socioeconomic status, or what was the socioeconomic status of these patients? Do you know why I'm asking this question?
Yes, sir. Like for considering this Diogenes 2 polymorphism and all, socioeconomic status also signifies, and the autoimmunity part also.
How socioeconomic status influences those symptoms? Through Diogenes?
For testing, I had actually proposed a Diogenes polymorphism testing also. So for affordability of that system in India is actually.
There's a study across 15 countries in Europe which has shown that the hypothyroid symptoms in primary hypothyroid treated with levothyroxine are directly proportional to the GDP of the countries.
Okay, sir. Okay, sir.
That's a very true point, because the symptoms are very non-specific, right? We don't have any symptoms
Direct
that are hardcore and specific. At the same time, it's difficult for us to do genetic testing for all to decide which cohort will actually improve. So maybe a cheaper way of assessing and determining who can be given a trial is.
Ma'am, we could actually consider the Thypro score as a subset to actually.
Thank you, Dr. David, for that wonderful presentation. A big round of applause for the presenters. We have completed 5 presentations in the thyroid paper presentation this morning. One presentation is missing, and if Dr. Mukesh Darshan could identify himself. So with the permission of the judges, please complete your scorings and do not forget to submit the scores. And since we do not have enough time left for one presentation, with the permission of the judges, I would like to conclude the session. And we will quickly move on to the next session, which is another set of oral presentations. Please. Another set of oral presentations on basic sciences, genetics, metabolism, etc. And we will begin right away with the next set of presentations. I think Dr. Rana Bhattacharya, Vijay Sarthi sir, and Dr. Haldar, Dr. Ashutosh Haldar is right there. Vijay Sarthi sir and Ashutosh Haldar sir, please, on the front, please. Rana sir will be there. Can I have a show of hands for the presentations for the 10 to 11 session? Please come to the front row. The front row to the, in the front over there, just behind the sofa over there. The presenters for the next session, please come in the front row. We have two judges. Rana sir is also here. So we plan to begin in 2 minutes. Six presentations in this session. I think 4 have been submitted. If Dr. Shweta Kohil and Dr. Anand Kumar are around, please identify yourself. Dr. Anand Kumar. Dr. Sanjana J.M. Dr. Ruhi Nanda, Dr. Abhinay M. Dr. Abhinay. Dr. Shweta Kohil, Dr. Abhinay. if the judges have received the scoring tablets. There are 6 presentations for the information of the judges on the panel that you see in front of you. You have to click on the scoring system, and there are 5 items on which you have to score. Please save and submit the scores. Do not forget to submit the scores. We begin our first presentation this morning, which will be by Dr. Anushtup Mukherjee, which is a study of genetic defects and heavy metal contamination in patients with renal tubular acidosis, presenting from pan-Gangetic and rare regions of West Bengal. Anushtup.
Good morning, everybody. Good morning, respected judges. So from beginning with, renal tubular disorders, as we all know, is an area of enigma for us clinicians. And the accurate diagnosis, it requires high index of clinical suspicion and thorough biochemical evaluation caused by genetic or acquired defect in ion channels and various nephron segments. But it has been found out by various clinicians that there is demographic and epidemiological clustering in certain pockets of West Bengal, which is an area of significance not yet studied. And so it is hypothesized that there might be a possible environmental contaminant in either water or soil or both that might be the culprit behind this demographic clustering. So a study done in Thailand, it showed that distal RTA is endemic in the Lao Thai population in the northeast region. Another study done in West Bengal, it showed that renal tubular acidosis is actually very much prevalent in the rare districts of West Bengal, that is to the west of the river Ganga. However, one might argue that the center from which the study was done itself is located in the Rad district, so there might be some bias regarding that. Taking front from these 2 studies, a research hypothesis was made that there might be an environmental influences in the form of heavy metal contamination, which could act as a second hit on top of genetic predisposition that make patients of these areas of West Bengal vulnerable to renal tubular disorders. So aims and objectives: to find genetic analysis of patients with renal tubulopathies, and also to find environmental contamination in the form of heavy metals in drinking water and soil of patients with renal tubulopathies. So it was a hospital-based observational study done in the Endocrinology Department, Medical College, Kolkata. All patients of renal tubular disorders from South Bengal were recruited. 22 such cases have been recruited. Genetic analysis was done with whole exome sequencing. Heavy metals in soil and water was done by ICP OES technique in collaboration with Central Research Faculty, IIT New Delhi, and all thanks to Endocrine Society of Bengal for the research grant thesis for this study. Now, it was seen that around, for the 22 cases, 18 patients were male, 4 were female. The mean age was 31 plus minus 15.5 years. Among the clinical presentation, 13 patients presented with hypokalemic quadriparesis, 5 with isolated short stature, 2 with rickets, and 2 with bilateral nephrolithiasis. After completion of the clinical and biochemical diagnosis, 13 patients were found to have various forms of distal RTA, 4 had presentation of Gitelman-like tubulopathy, and 5 had presentation like Bardet-like tubulopathy. Now in the genetics, all the patients underwent genetic analysis. Among the 22 patients, 16 patients were found to have relevant genetically positive mutations, 6 were either irrelevant or insignificant mutations found on negative gene. But the most important point of this was that among the 16 patients, 13 patients had heterozygous mutations, and the rest were heterozygous, compound heterozygous or homozygous. It was also found, most importantly, that out of the 16 genetically positive cases, 14 patients had mutations in the same set of genes as was diagnosed after clinical and biochemical evaluation, so there was high congruence. And most important part was 82% of the mutations were heterozygous. Now, how to explain how an autosomal recessive disease is becoming manifest with a heterozygous mutation? There comes the our study or thoughts on demography. We found that yes, out of 22 patients, 20 patients were from the rare districts of West Bengal, as was hypothesized. So as we see, it's to the western of the Ganga. All the patients, most of the patients were from that same region. And it corroborated with the study which was done earlier, which also showed that the rare region of West Bengal. But the important point is, this time the referral center was a tertiary care center in Kolkata, from where patients are actually referred from all over West Bengal. So there was no bias. Heavy metal analysis were done using the ICP OES technique, and heavy metal screen positivity was seen for lithium and manganese in drinking water, and for lithium, cadmium, and arsenic in the soil. Now, this is the chart on the drinking water, which showed that we took the 19 patients. Which 19 patients? Those who were heterozygous and those 6 which who were negative in genetics. Among those, because we are hypothesizing that heavy metal could play a role in them. So among these, lithium screen positive in drinking water was seen in 9 of them. Manganese screen in drinking water was seen in 10 of them. Similarly, in soil, lithium screen was positive in 7 out of them, and cadmium screen was positive in 9 out of them. Arsenic screen was positive in 6 out of the 19. Important to note that 5 out of the 19 patients had a positive lithium screen in both soil and drinking water, as lithium is a known agent to cause distal RTA. Now these are the various studies which have shown the various mechanisms by which the heavy metals cause lithium nephrotoxicity. As we all know, its major mechanism is via distal tubular dysfunction. Similar in case of manganese, it's mediated mainly through oxidative stress and mitochondrial impairment, and thereby renal tubular damage. For arsenic mediated nephrotoxicity, once again oxidative stress, free radical damage and DNA repair mechanisms are there, but mainly for proximal tubular. Cadmium induced kidney injury also follows almost the same rule via oxidative damage and by free radical damage. Now, in case of the limitations for the study and the way forward, we think the small sample size was small. More patients needed to be recruited, and biological samples could not be tested by these ICP-OES. Mercury, which is an established nephrotoxin, was not tested in the samples. So conclusion, take-home message from this study was appropriate clinics and biochemical testing can often pinpoint at the genetic mutation that is thought biochemically. Autosomal recessive disease with heterozygous mutation, if patients clinically manifested, we should think of a second hit. And if there is a demographic clustering of a genetic disease, also we should think of a second hit, predominantly an environmental one, if possible. Thank you.
Yeah, so the first question is, how did you measure these metals in soil?
So actually, the surrounding area, the neighboring area patients were the residences of the patients. So they were asked to bring the soil samples, and this was measured in the ICP-OES technique. That is the technique by which in metallurgy or in geology, the samples, the soil sample or the water sample, they are centrifuged and they are excited to high energy states.
Please expand ICP.
Inductively coupled plasma optical emission spectrometry.
Right, so why not the biological samples considered? Because it could have been more attributable rather than the soil and the water samples.
Yes,
why
true.
the biological samples are not?
Sir, actually those are considered, is not that, but the current facility, it actually did not have that sampling. We are thinking of doing it in the consequent, in future.
Why do you think like that? So a lot of labs are doing just randomly for routine health check also all these metals.
Yes, sir.
So what was the limitation when you can do for a soil and for a water? Why not the serum?
Yes, sir, it could have been done, but the technique by which we used it, it did not permit us.
How did you define a lithium positive screen in soil?
So the WHO, there is a standard guideline for the WHO has set a criteria above which in microgram per gram or
What is the criteria exactly? Can you tell them?
yes, the criteria is the soil sample should have lithium by that technique greater than 20 microgram per gram.
Okay.
So this is defined for all other metals as well.
So what is the rationale in thinking that like there could be an interaction? So and how many of the mutations you found? Which genes they were found? Right? And what is the ACMG classification of those variants? Nothing was projected.
Yes, sir. Actually, the most of the mutations that we found were actually
You want to call them as mutations or you want to call them as variants?
sir, some were mutations, some were variants.
Call a variant as a mutation. Are you permitted to call a variant as a mutation? When?
Sir, a variant is would be called a mutation if it is either likely pathogenic or pathogenic to cause the mutation. But in most of our cases, we got it either likely pathogenic or pathogenic, and some I should say was of VOWS, that is variant of undetermined significance. Those were some of them are there, but since the most of the renal tubular disorder autosomal recessive, so heterozygous mutations in that clinically manifest made us think that.
Unusual to have that kind of a result. Usually, when you get a random variance, most of them will be variants of unknown significance.
Yes.
Very unusual to expect pathogenic or a likely pathogenic variants when they're getting a random, right? Probably you have to relook at the ACMG classification of these variants. How do you want to replace them or reclassify them?
Okay.
Okay, so flow, if at all, if you are thinking that there is a link, how do you further strengthen or disprove it?
Sir, first is to increase the number of samples that are studied, and also, as I have mentioned, that biological samples need to be studied and a correlation should be made. And also, the other metals, or sometimes we also see, apart from metals, there are other nephrotoxins as well, like say fluoride, which causes fluorosis. That can also be, they are assessed, it is not mentioned in the study, we have assessed in few, but that can be assessed for everybody, because all the patients, because fluoride is also an established tubulotoxic substance.
So another probably thing you didn't focus on as, you have two different types of tubulopathies. So one is a Bardet-Biedl
RTA spectrum, yes.
Did your mutations were particularly belong to that group only correlated, and what is the correlation of these positive screens in the soil with the Bardet-Biedl group versus RTA group?
Sir, it was actually the uniformity was there. I mean, more or less uniformity, because in the Bardet-Biedl groups as well, we also found that the mutation that is likely to cause Bardet, say that was present, but in a heterozygous form that I mentioned, likely pathogenic or pathogenic, and that is what made us think in that way to screen for.
But how do you think that the same metal burden is causing Bardet spectrum also and RTA spectrum also?
Sir, I think this is based on the mechanism of how the metals interact with the various nephron segments. For example, we have got certain metals that cause the distal tubular dysfunction. Similarly, some cause proximal tubular dysfunction. So maybe that same spectrum we have to. Lithium is majorly causing the distal tubular dysfunction. Cadmium, mercury, arsenic, these are more proximal tubular. So there is no mechanistic difference between those two. Usually they are all via vacuolar degeneration or oxidative damage. We hypothesized that same might be the case in case of thick ascending limb of loop of Henle, or maybe like that, sir.
Thank you, Dr. Anushtu. We move on to the next presentation, which is serial number 3 for the judge's reference. Dr. Anand Kumar, supervised ultra-short diagnostic fast in OPD for diagnosis of Insulinoma, a case series of 3 patients. Dr. Anand Kumar. There you go.
Good morning, all the judges and all the attendees. I am Dr. Anand Kumar from Indira Gandhi Institute of Medical Sciences, Patna, and I am presenting a case series of 3 patients who presented with hypoglycemic unawareness and hypoglycemic crisis in their history, and they were diagnosed with supervised ultrasound diagnostic fast for establishment of endogenous hyperinsulinism. So we all know that the gold standard 72-hour diagnostic fast is a cumbersome task to do, particularly in the resource poor setting, because it requires admission, long hours of fast, and there must be a skilled attendee, particularly resident, to supervise the test. And it is many a time it is not acceptable to many patients because of anxiety and fear of severe hypoglycemic symptoms, and also there is time and cost burden. Now in our setup we have only 2 OPD chambers, and we are only 2 faculties, no in-patient setting and no residents, so it was a very difficult task for us to do the test in our setup. So when the patient came to our setup, we discussed with the patient the limitations at our institute, and but the patient told us that I'm not going anywhere else, you do whatever you want to do here only. So we planned this test in our setup after reviewing the literature, and the basic hypothesis was that the patient with history of hypoglycemic unawareness and frequent hypoglycemic crisis, which will reach critical hypoglycemic target earlier as compared to other patients. So the basic thing was safety concern, and we all know that supervised protocol is the most important thing in these patients to undergo the test. And hypoglycemic risks are always there, whether the patient is inpatient or outpatient setting. Patient with hypoglycemic unawareness develop tolerance to lower glycemic threshold. Now this is whether adaptive or maladaptive is not known, but there is definitely there is a safety window for these patients. So the patient were advised to take frequent meals day before the test and measure the glucose every 3 hourly. Then the Department of Biochemistry and Emergency Medicine were informed day before the test, and details of the test procedure and risk explained to the patient, and consent was taken for the test. We stipulated maximum time consistent with the duration of our OPD, that is 8 hours after a light meal or in the morning. And the patient attended measure blood sugar every 30 minutes until they reached OPD, and subsequently we measured the blood glucose every 5 to 15 minutes, and critical samples were collected once the blood glucose was less than 40 mg/cent. Now the patient were infused 100 ml of 25% dextrose after collecting the critical sample, and they fed immediately to leave the OPD, and adequate blood glucose was ensured prior to discharge from the OPD setup. Insulin, C-peptide and cortisol were measured in our institute, while the growth hormone, blood ketone and anti-insulin antibody was measured in a private lab. Now if we look at the baseline patient characteristic, all the patients were obese with a young to middle age group, and all the 3 were female patients. The duration of total illness was 24 months in patient 1 and 2, while it was 60 months, that is 5 years in patient 3. The baseline HbA1c was very low. 8 m cortisol was 12 in patient 1, while it was low in patient 2 and 3. The liver function test, kidney function test and thyroid function test was normal in all the patients, and anti-insulin antibody was negative in all the 3 patients. Now if you look at the test results, all the patient developed hypoglycemia within a stipulated time period. Patient 1 and 2 developed endpoint at 2 hours, while the patient 3 took 7 hours to go into hypoglycemia. Then if you look at the insulin and C-peptide levels, it was consistent with the Endocrine Society clinical practice guideline for hypoglycemia. The insulin level, the time to develop endpoint was consistent with the insulin level, insulin glucose ratio and the C-peptide levels. Blood ketone were undetectable in all the patients, and the response of serum cortisol and growth hormone with hypoglycemia was inappropriate in all the 3 patients. So subsequently the patient were undergone CT scan or MRI. The patient 1 and 2, the tumor was localized with CT scan, which we can see in panel A and B, while in the patient 3, MRI was done to localize the tumor in head of the pancreas. In 1 and 2, the tumor was located in the distal end of the pancreas. They underwent laparoscopic removal. The tumor were localized by laparoscopy, and the patient 1 and 3 underwent enucleation, while the patient 2 was treated with distal pancreatictomy. Now if we look at the clinical implication of the test, so the duration of diagnostic fast can be predicted based on the clinical risk factor like the duration of hypoglycemic symptoms and clinical course of illness and frequency of hypoglycemic crisis. Then again, rapidity of weight gain can also be a marker to predict the duration of the diagnostic fast, and the presence and absence of hypoglycemic awareness is one more clinical indicator. So the strength was usually useful in the resource poor setting, while a small number of patients is the major limitation. So supervised ultrasound diagnostic fast can be helpful in the subgroup of Insulinoma patient, particularly in the resource poor setting. Thank you.
So you measured, you conducted this test in how many patients, out of which these 3 were positive?
Sir,
so was there any negative screen in the ETAs?
Sir, in last 3 years we have got only 3 patients of Insulinoma, and in all those 3 patients this test was conducted.
Before the diagnosis of Insulinoma, you must have done in many other cases where you suspected spontaneous hypoglycemia, may it be
no sir.
Okay.
We only get 3, each year we have got 1 patient.
So from the clinical feature, if you found that they possibly have Insulinoma,
yes, sir,
then,
yes.
then only you did
yes,
this
sir.
test.
Many patients of hypoglycemia were they came to our setup, but some of them were diabetic, they were on the oral hypoglycemics or insulin. So they were all excluded from
And
this.
your explanation for low cortisol and growth hormone?
Sir, it is already existed in literature that is published in NEGM.
No, what was the explanation you gave for low cortisol and low GH in hyperinsulinemia?
Sir, there is no, they have published this report in NEGM, but there is no specific.
No, explanation is there. Definite explanation is there. I thought you knew that, so I didn't pursue. Oh. The explanation is definitely there.
So why there is no response of GH and cortisol in patients who have a recurrent hypoglycemia? What happens? And why did you choose a cutoff of 40 to collect a sample when the endocrine society guidelines say that you can collect a sample at any level less than 55?
Yes, sir. Because the patient in those guidelines, there is mentioned that if the patient is having hypoglycemic range in the of about around 45 or less with symptoms of hypoglycemia, but there was no symptoms.
The guideline doesn't say that. Irrespective of the hypoglycemic symptoms, 55 is the cutoff to collect samples.
But that is for spontaneous hypoglycemia. If the patient has a spontaneous hypoglycemia and it is less than 55, then in that case.
So for your patients also, it's almost like a spontaneous hypoglycemia. You had a early morning meal, light meal. Patients are having hypoglycemia after 1 hour or 2 hours. It's nothing induced, right? It's all spontaneous hypoglycemia for your patients, right? And what was the cutoff for your insulin antibody levels?
It was 10, sir, 10 international unit.
Per
from
units
that.
Per
ml.
Sure.
Yes, sir, I think it's
Does
per
antibody
ml.
Units they are using?
I think it was per liter or per liter, I think. I'm not sure, sir, exactly. I forget that thing.
First question, like what percentage of patients on a 48-hour fasting will have hypoglycemia, and what percentage of insulinoma patients on a 48 hours of fasting will have hypoglycemias within the first 6 hours?
At 48 hours, sir, more than 70% of patients, they develop hypoglycemia. And in 72-hour fasting, more than 96% of patients, they go into hypoglycemia.
So when you're expecting people only 70% to have hypoglycemia by 48 hours, so why are you expecting people to have hypoglycemia within 6 hours? So what is the proportion of patients who will have hypoglycemia within 6 hours?
Okay, sir, because these patients are, they have hypoglycemic unawareness, and they have this inappropriate cortisol and growth hormone responses. Also, there is decreased this sympathioadrenal response. So that's why I thought that.
Why do you think they have hypoglycemia unawareness? It's not that they have any autonomic dysfunction like a diabetic patient. Why in insulinoma patients have hypoglycemia unawareness?
Even in the patient of insulinoma, they develop HAF is reported, sir.
Okay.
Yes, sir.
Thank you, Dr. Anand, for that
Thank you, sir.
insightful presentation. We move on to the next presentation in this series of oral presentations this morning, which will be by Dr. Sanjana J.M., and she will be talking about effect of gender-affirming hormone therapy on bone health and joint flexibility in individuals with gender incongruence, which is serial number 4. Judges, for your reference.
Good morning, everyone. Today I'll be presenting the effect of gender-affirming hormone therapy on bone health and joint flexibility in individuals with gender incongruence. This study received a research grant from ESI. As we all know, transgender individuals on undergoing gender-affirming hormone therapy, they tend to have an increased psychological well-being, and also the sex steroids are implicated in bone metabolism. However, both estrogen and testosterone tend to affect bone health. These studies in Western data are usually on the individuals who have started the therapy pre-pubertal using the pubertal blockers before attaining the peak bone mass. This similar data in Asian population differs because most of the hormonal therapy during transition is started post-pubertal after attaining the native bone mass. Although ISCD has set criteria to assess the Z-score using the gender's individual gender identity, there are still knowledge gaps which needs to be addressed when considering the Asian population where the hormonal therapy started after the onset of puberty attaining the bone mass. So hence the study aimed to assess the BMD in gender incongruent individuals on hormonal therapy. The primary objective to assess the change in bone mineral density at the start of the therapy and 1 year later. Secondary objectives was to assess the change in any bone turnover markers, both the formation and resorption, and also to assess if there is any possible changes with the joint flexibility on the therapy. These were my inclusion and exclusion criteria. Individuals aged 18 to 40 years who met the criteria for gender incongruence as per the DSM-8 DSM-5 criteria were included. Any other disease, illness or on medications which would affect the bone metabolism, including the immunocompromised states, were excluded. 60 transgender individuals were included, of which 34 were transgender women and 26 were transgender men. They were followed for a period of 1 year. At the end, there were 19 transgender women and 17 transgender men. 5 of the transgender men lost to follow-up and 9 were lost to follow-up in transgender women. Bone mineral density was assessed using hologic at the lumbar spine and femoral neck. NANS database was used for the reference, and Z-scores were computed using the individual's gender identity. DEXA was performed at the onset of hormone therapy and 12 months later. Blood samples were analyzed for calcium, phosphorus, vitamin D, and testosterone, estradiol. Bone turnover markers like P1NP for formation and beta CTX for resorption were analyzed at the baseline and also 1 year later at the follow-up. Hormonal protocol, transgender women, most of them were on estradiol valrate oral medications 4 to 6 milligram per day. 4 of them were on transdermal estrogen. GnRH analogs were leuprolide, which received at 11.25 mg once in 3 months. Only 1 of them was on aldactone. Transgender men, all of them were on intramuscular injections of testosterone enanthen 250 mg. Only 2 of the transgender individuals were on transdermal testosterone. Joint flexibility were assessed using the shoulder stretch and sit and reach test as shown. Before performing a test, 5 minutes of warm-up was done, and average of the 3 was taken. Inability to touch the feet or the toes to be taken as negative. Any overlap or just touching were taken as positive. These were the results. There were no much difference in the age, BMI. Only the thing which differed was the lumbar spine. Transgender men at the baseline tend to have a higher BMD at the lumbar spine compared to the transgender transgender women, sorry. Coming to the biochemical parameters, most of them were there were no significant changes between the transgender men and the transgender women. However, the testosterone at the transgender men at the baseline was 34.1. This is before the start of treatment. And estradiol in the transgender women was 36.26 picogram per ml and 114.20 picogram per ml, which were in transgender men and transgender women. Only these 2 hormonal values were significantly different as expected. Coming to the baseline and follow-up data in the transgender women, though there was a significant gain in the BMD at lumbar spine and femoral neck, only the lumbar spine BMD had a significant gain which was more than the least significant change, and there was also increase in the bone formation markers which also was more than the least significant change expected. And transgender women, though there was a significant gain, almost maintained the baseline and the follow-up BMD. The change observed was not more than the least significant change. However, the bone formation markers tend to decrease in transgender women, which was more than the least significant change. Both the transgender men and transgender women attain the required level of the hormonal values needed. This is in comparison at the baseline and the follow-up. Baseline transgender men had higher BMD, but only thing which differed after 1 month was at the femoral neck, which had higher BMD compared to any other. Coming to the assessment of joint flexibility, transgender men showed no much change with the joint flexibility. However, transgender women showed a sit and reach, that is a lower body flexibility, a minor improvement which requires further imputations. Coming to the discussion, yes, GHT hormonal therapy does have a positive effect on skeletal health. In transgender men, there was a significant increase in BMD in neck, probably because of the anabolic effects of the testosterone. However, the joint flexibility that we have seen in the transgender women hint at a potential musculoskeletal effects which needs a further evaluation. Comparing the other studies from the Western data by VPs et al. In 27 and Boba et al. In 2023, it's an Indian data. All this study, first and the second study were on the longitudinal, but the Indian study was only one which has cross-sectional. All of them have measured the lumbar spine and femoral neck 1 year and follow. Both of them have showed a positive effect in the gender-affirming hormone therapy. Coming to the key findings, does have a positive effect, emphasize the importance of regular bone health assessment, and the recommendation is routine BMD if possible every 1 or 2 years, but better to do a baseline BMD. Further longitudinal research for a longer follow-up periods are necessary. The limitations of the study is the short duration and limited assessment of the lifestyle factors. These are my references, and thank you.
You mentioned gender-affirming surgery in a proportion of individuals.
Yes, sir.
So how many trans women actually had a gonadectomy as a part of GAS?
Whatever I have mentioned here, the GS, they had almost like nine of them, which are accounted for 26%.
No, all of them underwent orchidectomy.
Orchidectomies.
And these two in trans men?
They had underwent ovarectomy, sir.
What was the indication of ovarectomy?
Sir, some of the individuals who came here were post-gender-affirming hormone therapy, sir. I mean, they had already underwent a surgery and then came for the hormonal therapy. Those were the two individuals that already underwent. Sir.
Okay.
So, what were the statistical tests that were used to compare these two columns?
So for PMD, this was a normal distribution, so pair tests were used. P1NP and beta CTX, they were like not a normal distribution, so Wilcox and Ranksum was used. And least significance was calculated using 2.77 into the precision error and the coefficient of variation in case of bone turnover markers.
So did you also use the LSC for P1NP?
Yes, sir. The one in the brackets are the LSC based upon the coefficient of variation, 16.9%, with the coefficient of variation for P1NP being 6% and coefficient of variation for beta CTX being 9.4.
What is the importance of using a LSC for a hormonal evaluation?
When you're following up, if there is a change more than the least significant change, you can consider this to be of a therapy related than it by a mere chance.
So like see, after doing an evaluation for almost 1 year,
yes, sir.
So change is only 0.02. So you are recommending in your conclusion that you want to do a BMD every 1 to 2 years for these individuals. What are you going to achieve by recommending a monitoring of DEXA every 1 to 2 years for these patients?
If financially it is effective, it is better, sir. But in an Indian scenario, a second thought has to be given. But having a baseline will always be helpful, sir. A baseline.
Baseline, absolutely agree. But repeated measurements every 1 to 2 years, somebody who has had a very minimal risk of osteopenia or osteoporosis, is it not a waste of money and time for patients?
Better to be individualized is what I meant, sir. It's like if at the baseline, if you're having like a higher risk or lower, like you think it is not a stable one, it's better to follow up at least 1 to 2 years. Only, that is the reason baseline is a must. Following up will be a minimum 1 to 2 years based upon your stratification.
Is there, what is the prevalence of this gender dysphoria?
Sir, the exact prevalence is not available, sir, but based upon a 2011 census, they say that about 60% around, sir, because the exact prevalence in Indian data is not available because most of them will be missed out is what they have accompanied. No, not many come forward and disclose the thing.
Is there any shift in prevalence over the years?
Whatever we have observed in our center, what we can say is many of them have started seeking medical attention, but whatever we have mentioned here as the urban demographic, we have almost 80% of the people in the urban, but we still have a issue saying that most of them who are in the rural setup, they might not have been come up. So whatever 80% urban thing we have might be biased because we might still be missing up. So, but yes, there is an increase in the amount of people who are recognizing themselves.
So what type of gender dysphoria, men or women, which one is more common?
Right now it's a transgender women is what we are seeing most of the, which we have seen increased in our country.
Similar to every country or it's different?
It is different, sir. Some are gender non-incongruent also. The binary individuals are also there, sir. It's not only.
I have a last question. Okay. So how do you interpret this change at BMD at femoral neck? What was your conclusion?
So probably it was the probably in transgender men it was probably because of the anabolic effect of the testosterone is what we think of.
See, like, but the very fact that you have to see is that the BMD may be changing. It may be statistically different. What is a Z score? So it's an unusual change because the Z scores are not different.
The Z scores
So
are not
that's
different.
absolutely how the conclusion should be no change in the BMD.
Absolutely,
Right?
that was
So
my.
you cannot conclude that it's different.
That's why we want a follow-up data for a longer duration if there is any.
That's okay.
Irrespective of that, this is a usual change what you're expecting with age. That's why your Z score is not changing, only the BMD is changing. We cannot attribute this to the therapy.
Absolutely.
Okay, or the change in the treatment modality.
Because bone accrual is expected to occur in this age in inguinal individuals. So your Z score, unless it changes, you can't say it's changed.
Sure. No, sir. Though some of the neurological things has been proposed, they are still a hypothetical theory, and there is no actual etiology which has been told it, sir, as far as I know. Sir? Like at what age individuals? Here there are many of them have been in even in the pre-pubertal period, like 3 years, 4 years, or also been seen. Sexual imprinting. Around 1 and 2 years. Sir. Thank you. Thanks.
Thank you, Dr. Sanjana. Next up, we have Dr. Ruhi Nanda with her oral presentation on unraveling novel mutations in IGHT and implications in clinical practice, pathogenic drivers or coincidence. For the judges, this is presentation serial number 5.
A very good morning to everyone present. Growth hormone deficiency is a rare endocrine disorder which leads to severe short stature and significantly impairs the quality of life. Up to 30% familial and some sporadic cases of IGHT have been shown to have a link with key gene mutations like GH1, GHRH receptor, GLI2, and rarely BTK. Worldwide, GH1 is the most common mutation that has been found, but in Indian patients, the genetic basis of IGHT is still not well documented. The objectives of our study were to identify and characterize genetic mutations that were associated with IGHT and to compare the various clinical and biochemical parameters in patients carrying the mutations versus those who were not carrying the mutation. Our study was an ambispective study which included patients who were diagnosed with IGHT according to the Growth Hormone Research Society 2000 criteria. All patients who had acquired causes of GH deficiency, involved other pituitary hormone lines, or other causes of short stature were excluded from the study. All enrolled patients then underwent an MRI pituitary, which was done at baseline, followed by a whole exome analysis using the Illumina NGS platform to look for pathogenicity of mutations. On the basis of whole exome analysis, we divided into 3 subgroups. Group A, that consisted of patients with GHRH and GH gene mutations. Group B were those with pathogenic gene mutations of bone and or cartilage development. And Group C were patients without the mutation. After this, all patients were then administered growth hormone. That was 0.2 milligram per kg per week, and the height velocity was seen at 1 year. Our total number of participants were 29, which included boys and girls being 59% and 41% respectively. The intergroup comparison was done using ANOVA, and the post hoc analysis was done using the 2Ks HST. On whole exome analysis, we found out that 8 patients revealed a known pathogenic mutation in the GHRH receptor gene, 1 novel likely pathogenic mutation in GHRH gene, and 1 variant of uncertain significance in GH1 gene. In Group B, we had 9 patients with pathogenic mutation in genes implicated in the collagen and or cartilage development, and Group C had 10 patients who were negative for any mutation. Group A results and Group B. On examination in history, we found out that 34% patients had a family history and 17% had consanguinity, both being higher with the GHRH receptor group. On examination, cleft lip and cleft palate were highest, being 24%, followed by nasal bridge abnormalities being 20%, followed by hypertelorism, single central incisor, and micropenis being 3% each, all again higher with the GHRH receptor mutation. On MRI pituitary, we found out that 24% patients had a pituitary abnormality, 17% had a hypoplastic anterior pituitary, and 7% had an empty sella, all higher with the GHRH receptor mutation. Comparing between group A, B, and C, the age of presentation was maximum with group A being 12 years, and group C was least being 8.9 years. The Gmax on stimulation was least for group A, and MRI pituitary abnormalities were highest with group A and followed by group C, which was 30%. There was no significant difference that was noted in the height SDS or the serum IGF-1 levels amongst the three groups. Comparing the height velocity with group A, it was 10.2 centimeters, which was highest, followed by group C being 8.8 centimeters, and then group B being least, that was 8.5 centimeters. Group A was significantly higher height velocity than B and C, but no significant difference was noted between group B and C. So looking at the global literature, we found out the GH1 mutation was most common mutation globally, but at variance with the world literature, our study showed a predominance of GHRH receptor mutation over the GH1 mutation, which is reaffirming the regional diversity in IGHT. There was a greater increase in height velocity in group A, which was followed by group C and B after 1 year of growth hormone administration, and pituitary abnormalities on MRI were seen in 24% patients. The strengths of our study are that very few Indian studies have been done to evaluate the genetic basis in IGHT. We report a novel mutation in GHRH receptor gene, and the response to growth hormone was studied in all the three subgroups. But the weakness lies in the small sample size, the lack of long-term follow-up after growth hormone administration, the lack of familial genetic screening, and proof of pathogenicity test could not be done for the novel mutation. To conclude, our study showed that GHRH receptor mutation was more common than GH1 in our cohort. The height velocity and MRI pituitary abnormalities were higher with the group with mutation, and we identified a novel likely pathogenic mutation. The funding is by the Endocrine Society of India. Thank you.
In the statistical analysis,
yes,
you did ANOVA to compare the
three groups, yes,
for height velocity, right?
Right.
So what are the kind of distribution? Were they normally distributed or non-normal distribution?
A normal distribution, sir.
Okay.
And graph did not say that.
Yes.
Yes.
A wide variation.
So there was,
but the data could be a normal distribution.
Yes, sir.
Because one of the basic presumption of doing ANOVA
yes,
has to be
yes, sir, but it yes, sir, it was actually when database. Yes,
again, just cross-check your data.
Right,
I think.
And even you did not mention the measure of dispersion for your height velocity or any parameter you gave. Everywhere you just give the average. So that's not the way of giving a data to anybody, right? So what were the measures of dispersion we had to use? What were they? For example, height velocity, you said 10.5. What was the measure of dispersion in that?
Okay, so mention that,
sir. Dispersion for this? What are the measures of
no,
dispersion
sir,
you can use along with the mean?
We did not use, sir, in our study.
Sorry?
We did not use, sir, in our study. Measures of dispersion.
It must be there. It must be there. Again, you have to go back and look at your data. It must be dispersion has to be
no,
there.
No, sir, it was there, but we've not mentioned in our study, sir, being a limitation.
So there was a patient with NRP2.
Yes, sir. Right? Yes, sir.
So what is the disease that results due to this?
So acromesomelic dysplasia has been seen, sir, with NRP2, which is the MAR2 type has been seen, sir. And
what is the clinical relevance of NRP2 now?
Sir?
What is the clinical relevance?
In, sir, the
NRP2 that has a wide, implication now. What is that?
So it has been now, it has also been seen that with growth hormone signaling, there is a relation that has been found out, sir, that there is a down regulation and signaling, sir.
Are you aware of vosoritide?
Yes, sir. Vosoritide, yes,
Where does
sir.
it work?
So
which receptor it works on?
It works on this receptor only, sir. That's on NRP2, yes, sir.
So what is vosoritide?
Vosoritide says it has been recently used for achondroplasia. Sorry, for
agonist. What is called? Sir? Which analog it is?
Sir, it is?
Which analog?
Which analog is it? Vosoritide.
NRP2, so it works on that only, sir.
It's called as like something.
Is it a direct? Okay, yeah.
Yeah, some analog it's called as. Okay, The other surprising finding is a very good height velocity change, what we saw in skeletal dysplasia group.
Yes, sir.
Right? It's a varied group. Everybody had a uniform height gain and height velocity of almost 6+.
Yes, sir.
Which is very surprising.
Yes,
so
sir.
what was their pre-treatment velocities?
Pre-treatment velocity, sir, we had only a few patients, sir, because when we enrolled the patients, there were some patients who did not have a previous height. So for the few patients that we had the data, out of the 9 patients that we had the height velocity of 4 patients, and those 4 patients, the height velocity was approximately between 5 to 6 centimeters, sir.
Another fallacy I saw was you gave a dose of 0.2 mg per kg per week
Yes.
for everyone.
Yes,
right?
sir. Yes, sir.
So with that small dose only, everybody is going.
Yes, sir. We started with low dose only, sir, 0.2 milligram per kg.
Escalate it?
Sir, because we just saw the height velocity at 1 year, sir, we could not escalate, sir, but we plan to follow up, sir.
You want to wait for 1 year to escalate a dose of growth hormone in any patient?
No, sir, we usually don't wait, sir, because we see at 3 months, we see, sir, the levels of IGF-1 and we can plan to escalate, sir, but
Was it done for
no, sir, but we did not do, sir, because we wanted to keep the same basis for all patients, sir.
Because you're completely changing the practice and completely also saying that all these, the non-GHD patients
Yes, sir.
are responding so well to 20 milligram,
Yes, sir.
20 microgram per kg per day.
Yes, sir. 0.2 milligram, yes, sir, per kg per week, yes, sir.
If that was the scenario,
Hmm.
so we would have been the happiest people to start every skeletal dysplasia on growth hormone.
Yes, sir. So that is what we found out, sir, that was different from the literature that is usual, yes, sir.
It's not possible or feasible.
But so the variants that we found were actually variants of uncertain significance, sir, so we can't, the gene
They had
mutations.
other features of skeletal dysplasia?
No, sir, we did not find any bony deformities in all the patients that we had, sir. In all the 9 patients that we had. Yes, sir, biochemically GHD, sir, but there were no bony deformities that were found.
You have a case of VUS which you included in statistical analysis.
Sir?
One case of VOUS.
VOUS, yes, sir.
Usually you do not consider in statistical analysis or
Yes, sir. Yes, sir.
cause relationship.
Yes, sir.
So is there any supporting evidence that you can make VUS as a likely novel variant?
Yes, sir. So we can use either segregation analysis or functional analysis, sir, and then we can reevaluate, sir, if it is likely pathogenic. No, sir, we have not done, sir. In our study, we could not do because of the restriction of the cost.
There is lot of information available in the world.
Yes, sir. Yes, sir.
You can make it.
Hmm.
What is the allele frequency of that variant?
Yes, for
You
this
have
particular variant, sir, they had shown it to be 0.06, sir, I believe, sir, but I am not very sure. I'll recheck, sir, and...
If it is a very, very
Yes, sir.
rare than 1 point.
Yes, sir.
Then you can make protein modeling study.
Yes, sir. Yes, sir.
Did you try that?
No, sir, we could not do that in our
It
study.
fits in protein and knock out the protein, so you have those evidence.
Yes, sir, but because...
And then CAD score.
CAD score, yes, sir.
You would
We
be-
could, no, sir, we could not.
So you need homework
Yes,
to
sir.
make as a novel variant.
Yes, sir. Yes, sir.
Thank you, Dr. Nanda,
Thank you,
for that insightful presentation. Our last presentation for this session is by Dr. Abhinay M, genotype-phenotype correlation of Bardet-Biedl syndrome, a single center experience. And a reminder, do we have Dr. Shweta Kohil? Dr. Shweta Kohil, I think one presenter missing in this series. Could you please identify yourself to the crew? Dr. Shweta Kohil. And judges, the 6th presentation in your series. Dr. Abhinay. Please start.
Good morning, everyone. My presentation is on genotype-phenotype correlation of Bardet-Biedl syndrome. So Bardet-Biedl syndrome is a rare autosomal recessive multisystem disorder, part of a non-motile coelopathies. Basic defect is a defect in the primary cilia, which is important for key development and signaling processes. It is genetically heterogeneous, that is, loss of function mutations have been reported in around 26 genes till now. Most involve BBS genes, that is BBS 1, 2, 4, 5, 7, 8, 9. Globally, BBS1 is the most common mutation. So, coming to a diagram of Bardet-Biedl proteins and the relationship of primary cilium. So, this is the BBS-zome proteins. As I already told, 1, 2, 4, 5, 7, 8, 9. Among them, these have to be assembled for the proper functioning of the primary cilium. This BBS6, 10 and 12 are the chaperonin proteins which are important for the assembly of this BBS-zome complex. So any mutation with respect to chaperone protein 6, 10, 12 or the BBS-zome complex, among them core proteins 2, 7 and 9 will lead to severe phenotype and also can lead to developmental abnormalities in kidney. So the diagnosis of BBS is based on Biedl et al. Was given by Biedl et al. Criteria wherein either 4 primary features or 3 primary features and 2 secondary features are required. So major features include retinal dystrophy, polydactyly, central obesity, hypogonadism, renal anomalies and cognitive impairment. So with respect to India, the genotype-phenotype correlation data is limited. So our aim, objective was to establish genotype-phenotype correlation in patients with Bardet-Biedl syndrome. So source of data was from our OP and IP patients, a cross-sectional study over a period of 6 months. The inclusion criteria included clinical diagnosis of BBS based on Biehl's criteria. So after enrolling the patient, detailed clinical data were taken and whole exome sequencing were done. So 15 individuals were screened who fit according to the Biehl's criteria, and 4 were excluded because of incomplete records. They underwent next generation sequencing, around 11 patients, and among them 2 turned out to be genetically positive Bardet-Biedl syndrome, so they were excluded. So remaining 9 index patients were there, and genotype-phenotype correlation was done. So this is a table showing phenotype and genotype characteristics of all the 9 patients. The median age what we found was around 14 years, and consanguinity, parental consanguinity was almost present in 8 of the 9 patients, and most of the variants were truncating type. That is, almost 7 out of the 9 patients had frame shift or nonsense mutation, and all had homozygous pathogenic or likely pathogenic variant. And almost 100% of them had obesity, 90% of polydactyly and retinal dystrophy. So coming to the common genes which are involved were around BBS10 was 3 patients, and BBS10 of 3 patients each, and BBS9 of 2 patients. Among this BBS9, 1 patient had small left kidney. And coming to minor features, most of them have brachydactyly, and diabetes was found in around 4 patients. And BBS9 patients who also had renal anomaly also had neuropsychiatric problems with respect to seizures and cognitive impairment. So with respect to comparing truncating with non-truncating mutations, truncating mutations was obviously found more, but still we could generalize that the age at diagnosis was earlier and the rate of cognitive impairment and hypogonadism was more, implying protein loss of severe protein dysfunction leading to earlier onset and severe phenotype. This is a patient with BBS10 mutation with polydactyly and central obesity, and this is one more patient with BBS2 with polydactyly, central obesity and cognitive impairment, and this is one with BBS9 mutation with polydactyly operated in the hands, and then brachydactyly with central obesity with renal anomaly. And this is one patient, a 14-year-old patient with BBS12 mutation with polydactyly, obesity. Initially, he has lost weight recently in 1.5 years because he has developed severe diabetic kidney disease. And coming to discussion, 2 key observations from Indian population. That is, one is distinct genetic distribution in the cohort and clear influence of mutation type on clinical presentation. BBS10 and 2 where the majority of almost 2/3 of the cases points to population specific signature. Globally BBS1 predominates, but it is absent in our series. And then parental consanguinity almost in 90%, but still globally we could see that obesity, polydactyly, retinal dystrophy was almost similar. And with respect to impact of mutation type on clinical expression, truncating mutations with 77% had early onset and with broader involvement. So loss of function severity, maybe we could suggest it correlates with clinical presentation. This also supports that chaperone-like genes like 6, 10, 12, among the 10 cause more severe phenotype, and BBS10 globally had severe renal dysfunction by the age of 8 to first to second decade, but our cases showed only mild variants. So it could be due to modifier genes and environmental influences. So this is data comparing the other cohorts. Renal impairment was less. The main thing is small samples and single center design was the limitation, but given that it's a rare thing, we could take the. Why is that important to go about this is forming genetic strategy, surveillance protocol, truncating chaperone genes, and metabolic screening. So the thing is, why is it important to do a genetic screening for the patients is, pre-symptomatic genetic testing could be offered to siblings by school age in consanguineous families with truncating variants if identified. Renal and BP monitoring in high-risk nephropathy cases could be done. routine glucose and lipid screening could be done. And genetic panel optimization, first line testing in India could include 10, 2 and 9. And then conclusion, these insights underscore the importance of population tailored genetics, vigilant renal and metabolic surveillance. Integrating strategies in endocrine practice compared earlier diagnosis, individualized therapy, personalized care, basically improving the quality of life.
In this study, you only included those with mutation positive or whatever the genetic abnormality positive, or any patients with clinical features of BBS?
So first, patients who fit the diagnostic criteria of Beals were included, sir. Then we went ahead with genetic studies.
Right. So what was your yield?
So almost
100%.
100%.
Okay, so that's much more than that is expected, and it's a huge kind of.
We are actually screened for 11 patients, sir. Sorry, sir.
Yes.
11 patients, and then 2 were excluded, sir.
Why?
The point there is 2 were excluded because of Prader-Willi syndrome. How
Yes.
did an NGS give a diagnosis of Prader-Willi syndrome?
Exactly.
Sir, after that we went with that, what do you say? MLPA was done, sir, for that.
What MLPA?
What kind of MLPA?
I've forgotten.
Why you suddenly thought of Prader-Willi in somebody whom you suspected to be
Exactly. I mean,
sorry, sir.
In someone whom you suspected a Bardet-Biedl initially, why you suddenly suspected a Prader-Willi and sent a genetics for Prader-Willi?
Sir, actually, as a part of it, initially after that NGS was negative, it was sent, sir, for the diagnosis.
But they had polydactyly, postaxial. They also had visual impairments.
Yes, sir. Yes, sir.
But then, are those fits with this
That
PWS?
no, sir. That patient did not have retinal dystrophy. Even in our cohort, the incidence of the retinal dystrophy is not almost 100%, almost 90% it was there, sir.
So what are the other
so
obesity syndromes with retinal manifestations?
One is Alstrom syndrome can be there, sir. And then Senor-Loken syndrome, one more is there, sir. Autoimmune that can have
more classical syndromes which can have dystrophy. Obesity syndrome, genetic obesity syndrome with retinal dystrophy. You have to mention 2 more. Okay. How did you do the, which statistical test was used to compare the truncating and non-truncating?
Fisher test, sir, because sample size was less than 5.2, sir. That's why.
Okay. So again, you want to do a genetic panel optimization. What is the need of genetic panel optimization when you have so many genes? And it may be possible that it may be in some other gene other than these 3 known expected genes.
So with respect to Indian data compared to global data, there's a difference. In
True, but like everybody is undergoing a next generation sequencing of all the known genes. On the top of that, what extra genetic panel optimization you want to do with respect to these 3? We should have the same depth of analysis for all the known genes which are there, irrespective whether they're in India or not there, because you may get one particular case of BBS1, though it's not there in your study. So why are you suggesting a specific genetic panel optimization only for these 3 genes?
Sir, it could be, anyways, studies ongoing, sir. We are still recruiting. So at once there is a larger study, we can.
But before that, you need to talk with your geneticist to optimize this, no? Because you have to look at the depth of all those genes and then compare. And you mentioned founder effect as a possible etiology. Did you look at the geographical distribution of those individuals?
Yes, sir. They were all restricted to our Belgaum and border Maharashtra area, sir. So we could feel we.
Is WES is a right test for screening?
A clinical exam would have been suffice, we felt.
That should have been done.
Yes, sir. Initially for.
And we had number of genes, not many. I think 30 to 40 genes.
Yes.
It should have been much better with a very high depth, plus also deletion you can include in that. That should have been the first.
Still, for the first 2 patients, whole exome was done, sir.
When you have negative that BBD panel, then only you can go for whole exome sequencing. Otherwise, whole exome sequencing will miss out on many things.
Yes, sir. Actually, only 2 patients initially were done with the whole exome, and then we continued with the clinical exome itself, sir.
Thank you, doctor, for that presentation. And if the missing presenter is not there, this brings us to the end of all oral presentations on the platform of ACCON 2025 Kolkata. I thank all our judges, and I would like to double check if they have saved and submitted the scores, excepting one presenter which is absent, I think presenter number 2, all other presenters. And I'd request the team to please help the judges finish the scores and collect the equipment from them. Quickly moving on to the next session for this, which will be an interesting session on research, responsible research, ethics at the core. To chair the session, may I invite Dr. Shubir Chandru Shor. Dr. Shubir Shor is Assistant Professor at IPGMR Endocrinology Department, Kolkata. Shubidda, on the stage, please. And we have 2 talks in this series by 2 eminent speakers, Dr. Nandini Chatterjee and Professor Shantanu Tripathi. Will be talking about interesting aspects of research, some very basic and very ethical aspects about research. Dr. Shubir will invite and introduce the speakers. I would like to invite Dr. Nandini Chatterjee on the dais.
So now, ethical issues often not discussed in all the conferences. Now we have the opportunity. Now I'm inviting Dr. Nandini Chatterjee for next session on informed consent. She is Professor Department of Medicine, IPGMR, editor in the JAPI API West Bengal branch, and so many feather in her crowd. So without wasting much time, I'm handing over the session.
Okay. Thank you very much, and a very good morning to all. So the topic allocated to me by the scientific committee was informed consent in research. Now, we all are aware that research is important. We need it in everyday life for scientific knowledge dissemination as well as for enhancing our career opportunities. But it is very important that we should be aware of the ethical issues that are integral to any research process. So what is informed consent? Informed consent is the process in which a subject voluntarily confirms his or her willingness to participate in a particular trial. But how will she consent? She will consent, she or he, only after being informed about all the aspects of the trial that are relevant to the decision. Informed consent has to be documented by a written, signed and dated informed consent form. So, we are having so many trials every single day, and the participants who are helping us by taking part in that trial need to be aware about every aspect of the process that is going to continue for a definite period of time, and only then, after that person understands the full implications, will give consent to become a participant. What is the goal of the informed consent process? It is to provide people with sufficient information so that they can make informed choices whether to begin or continue participation in clinical research. I would like to draw your attention to 2 words. One is begin, another is continue. Begin means that the person is agreeing to participate in the trial, and continue means he or she is free to withdraw from that research at any point of time if he or she feels so. So there are 2 things to this signing of the informed consent. Now, the origins of the informed consent can be traced back to ancient times, and it is the essence of the medical profession that we will do no harm, that every physician's duty is to act in the patient's best interest. Having this in mind, there are many examples, horrific examples in human history where human rights were violated. We are aware about the Nazi human experimentations during the Second World War, when there was no issue of consent and many atrocities were done. Next, the Tuskegee syphilis experiment, which went on for 30 long years. A group of vulnerable people were studied for disease outcome without giving consent or any kind of intervention. However, there is still hope, because even after such atrocities have been committed, various bodies have come up with sets of guidelines and regulations which have told the physicians that you cannot do such things. You have to abide by certain rules which will take care of human health, interest and well-being. In the 20th century, the Nuremberg Code in 1947 and the Belmont Report further solidified this informed consent as a fundamental ethical requirement in any research or medical practice. The Nuremberg Code is a group of research ethics principles for human experimentation, which was a result of the famous Nuremberg trials at the end of the Second World War. It was emphasized that the voluntary consent of a human subject is absolutely essential. And it is the responsibility of the investigator to get that consent from the subject. The Belmont Report also had several discussions on different aspects of medical practice and research, but the one which I will be stressing upon are the 3 basic ethical principles. What are they? They are respect for persons, which means that individuals should be treated as autonomous. People with diminished autonomy should be protected. Number 2, we should maximize benefit for research products and minimize risk, which means do no harm. And 3 is justice. That is, the benefits and burdens of any research should be equally distributed among all subjects. So, autonomy, beneficence and justice. Then came the Declaration of Helsinki. I will not go into the details, but what is important that here the concept of the proxy consent from a legal guardian came up. And here I would like to just stress upon the term the legally authorized representative, who is another person apart from the subject if the subject is a minor or if the subject is unable to give consent, like someone with severe cognitive disabilities. Now, where do we require informed consent? Topic of discussion today is informed consent in research, that is human clinical studies. However, consent is mandatory whenever you are giving some form of therapy. You need to discuss with the patient, disseminate patient information, or you are going to have some specific procedures done on the patient. Is there some surgery to be done? Is there a blood transfusion? And even a very sort of a medication infusion that may have some side effects. If you are going to administer that, you need to take an informed consent. We are also aware that in any anesthetic procedure, before that, we need consent. But let us concentrate on research today. So what are the components? One is information that the investigator is going to share with the subjects. Number 2, which is extremely important, is comprehension. You as a physician are sharing information, but your subject is understanding nothing. So the procedure, this process is totally null and void. So not only sharing of information, but making sure that there is full comprehension or understanding on the part of the subject is important. And after understanding, voluntariness means not under any duress. The person himself or herself will voluntarily say that, yes, I am ready to take part in this research. So what is the framework? The framework of this process is that the information provision and sharing will first be discussed within the research team. Then there will be interaction between the potential participant and the researchers. The participants will fully understand what is going on. Then they will either accept it or reject it. If they reject it, it is the end of contact with those subjects. However, if they accept and give consent for the research, then there will be follow-up. First, we have to properly document it. So, it has to be either written, or if it is verbal, it has to be recorded via video and audio, and there should be a witness. Now, there are many difficulties that researchers face and many problems when they go about this process of getting the consent from the subjects. First of all is the use of technical language. Of course, your lay person may not understand fully the technicalities of the medical terminologies, and it is your responsibility to break it up in understandable way. Moreover, sometimes when you are starting a trial with a new drug or a new procedure, then there may be some intrinsic uncertainties regarding the process and the medical information. Moreover, on the back of the mind of the investigator, there are worries about harming the patient, even alarming the patient. If you talk too much about the risks, there is one possibility that your patient will be frightened and say, "Nah, Baba, I am not going into this." Moreover, there are time pressures. Sometimes the consent form and the patient information sheet may run into 5-6 pages. And the doctor has to fully explain this to your subject. So in that case, there are time pressures which may sometimes cause problems. What are the problems that the patients may face? Obviously, they have limited knowledge about the medical, the diseases or the treatments available. Sometimes they may be inattentive or distracted. They may be worried about their own health and may not be listening to you when you are talking about the disease. They may be overcome by fear and anxiety. They may be selectively hearing due to some denial or fear. So, all this, what happens? There will be less comprehension on the part of the patient. What you can do? There is one process called teach-back method. Here, what you can do is that you again ask the patient, "Did you understand what I explained to you all this time?" And you can give some example and reinforce whatever you have said so far. There may be language barriers. This is very important. The medical person or the investigator and the patient may have different mother tongues, and there may be a problem of understanding. There may be cultural differences. This is also extremely important. There are some groups where the patient herself or himself does not take any decision in the family. Sometimes a male representative or the patriarch of the family takes all the decisions. So these are the dilemmas the investigator faces. After explaining for half an hour to your patient, the patient will say, "Ebar বাড়ির লোককে একটু ডাকছি, আপনি আবার বোঝান." We face it every day in our medical practice. So what will you do in that case? That you need two people to sit there and understand what is being told. So all these difficulties in explaining to the patient leads to incomplete disclosure, inadequate documentation, and there may be patients with impaired decision-making capacity. So the ICMR has published guidelines how to go about this process of informed consent, and they have been revised. The new drugs and clinical trials rules also were added, which gave some more points. The basis is that the informed consent document will have two parts. One, the information sheet. The patient information sheet will explain everything about the research and the relevance to participation, and there will actually be a consent form where the participant will sign after having understood that information. So what are the components? The ICMR has put down the components. First, you have to mention that this is research. You have to tell what is the purpose and methods of that research. Mention what is the duration and frequency of contact, what are the benefits, what are the foreseeable risks. And you have to also assure that this will be a confidential process. It will not be shared. You have to also be very clear about any reimbursement that is going to happen. If there is any research related injury, it should be clearly mentioned whether there will be any compensation or free treatment, whatever is to be given. And the patient should know that he or she has the freedom to withdraw from the research at any point of time. He has that right if he feels that this is not suiting him. The identity of the research team and contact persons with address, phone number should be given. There are also some additional elements in the form. I am not going to read this out. They are all available in the sites. The drug clinical trial rules also added some things like a possibility of failure of the investigational product should be mentioned clearly. It is not that because this is a trial, everything will be a rosy picture. There may be failure. And also it should be mentioned that placebo group shall not have any therapeutic effects. There are some areas where there may be an Okay. So, thank you. So, there are some areas when consent may be waived, because this is very important. There may be some situations like research cannot practically be carried out without the waiver, if there is a situation like that. Retrospective studies where the participants are de-identified. You are doing a retrospective study. There are some participants who cannot be contacted for consent or are de-identified. You can go about it without taking consent. Certain types of public health studies or surveillance programs can be done in such case. Research on data available in the public domain. If the data is available in the public domain, then you can take it. It is no need to take individual consent. And research during emergencies and disasters. There you can go about. So when the patient is too incapacitated, you can take consent from a legally authorized representative and not from the patient. And as I said, in life-threatening emergencies, there may not be time to obtain consent. Where we need re-consent, if you are doing a long-term study, if there is a change in the treatment modality, if you are thinking of publishing that study where there is a possibility of disclosure of identity, or there is availability of new information which has to be added to the protocol. In these situations, you have to take re-consent. What is assent? Assent means when you are dealing with children, there is no need to document the assent in people below 7 years of age, and between 7 to 12 years, a verbal assent may be taken in the presence of the parents or the LAR. One last thing that I would like to say is that about the e-consent or the electronic informed consent. Because in this digital times, you may not do so much of paperwork. You can have the help of interactive platforms with multimedia like videos and audio to deliver the information about the study. And then you can go about taking the consent. It can be a combination of electronic as well as paperwork also. But there are some concerns about digital inclusion and data protection in this case. So to summarize, informed consent is a process, it's not just a signed document. There are various important landmarks in the past which has helped up to develop now the ethical guidelines for research, and the basic components are information, comprehension and voluntariness. Thank you.
Wonderful deliberation and joining the dais for, we will take question at the end of the session. Now I am inviting for our next session, ethics in genetic testing in endocrinology, inviting Professor Shantanu Tripathi, Principal and Professor of Pharmacology, Jagannath Gupta Institute of Medical Science, Lifetime Achievement Award in 2025 by Medical Pharmacology Society of India, and many more, published more than 200 plus research articles. Welcome, Dr. Tripathi.
Okay, thank you very much, and must thank the organizers for this opportunity to share the stage. But very few people in the audience. In any case, this is an important area, but very elementary, ethics of genetic testing in endocrinology. Of course, I was not told categorically that it is related to a session discussing about research, okay? But I can try to modify. This was the topic given to me. In any case, genetic testing, this is nothing but a process that examines individuals' genes, chromosomes, DNA, proteins, in order to identify if there is any mutation or change in the genes, genetic materials, which can cause or increase the risk of the genetic disease. And such analysis, when it is performed on body tissues, saliva, blood, other tissues, purpose is diagnosing existing condition in a given individual, identifying the risk in that person for developing genetic disorder. This knowledge can help in deciding the treatment, tailoring the treatment for that person, and helping to determine the vertical transmission to the next generation, to the offspring. And the same thing, this has been summarized in this slide again, confirming suspected clinical or endocrine diagnosis, predicting the risk either in the individual and also other family members and in the next generation, determining the molecular alteration so that to actually understand the pathophysiology of the phenotype so that we can decide the therapy more precisely. And this is the kind of diagnostic workup in endocrine disease. And at the top you can see that clinical diagnosis is must, or clinical workup is must first, and then to understand the essentiality of ordering a genetic test, that is the first step. And then one should go for the when it is felt that yes, complete diagnosis or confirmatory diagnosis would not be possible unless we go for a genetic testing, then go ahead. And then pre-test counseling is important. Information, informed consent, which has been discussed, in principle it will be the same here also, in clinical practice also. In genetic testing broadly, there are 3 types of testing. If we have a clear idea about, and I'm suspecting a disease where I know what kind of genes might be responsible, then you go for the single gene testing. That's what is called panel testing. That single locus associated disorder testing strategy is disorder specific test, which is actually targeted sequencing panels. Then if it is negative, then you go for the multi-gene panel, which is actually exome sequencing, whole exome sequencing. Or you can think of if it is also not providing enough inputs, then you go for the WGS or whole genome sequencing. We need to remember that there is also need for, there might be need for, many a times there is need for testing also the family members. So in the informed consent also, it is strategically more acceptable that informed consent is taken in a group, the individual patient as well as the family members. And then the average turnaround time, depending on the type of the testing, is 2 to 3 weeks or maybe a little more in case of in certain laboratories for whole genome sequencing. So that also is to be kept in mind, and whether and to what extent we should initiate therapy or not, that has also to be decided and has to be explained clearly in the informed consent process. This is again not going into detail. This is the trying to distinguish between the difference between the single gene testing versus the whole genome sequencing. Just to give an example like this one, the multiple endocrine neoplasia syndrome, that MEN1, MEN2 syndrome, and what are the phenotypes. So accordingly, and we all know the gene that might be responsible, they are different in case of MEN1 or MEN2, and accordingly we can think of ordering the particular genetic test, or one can think of going for the exome analysis or the whole genome analysis. This is about multiple endocrine neoplasia. There are issues like the considerations in case of pre-implantation genetic testing, which is done when which is performed on the embryos, typically at the blastocyst stage, and this is actually a consideration in vitro fertilization process, where people try to identify specific genetic conditions or chromosomal abnormalities before they are transferred to the uterus. And this process helps prospective patients to avoid passing on certain inherited diseases, reduces the risk of IVF failure or miscarriage, and increases the likelihood of healthy pregnancy. Now there might be an ethical question that whether pre-implantation genetic testing would be done always, okay, in all cases, or in some specific cases, whether it should be done in all IVF laboratories in all cases, or it has to be, okay, to be limited to certain cases. Similarly, newborn genetic screening also, whether there has to be a mandatory newborn screening for all children, or it has to be limited to certain specific, okay, conditions or specific necessity, whereby newborn, again, genetic test is, while in case of the previous one, it is actually the done on the embryo. In this case, it is done on the blood of, it is a vital blood test actually, which is done in the newborn 24 to 48 hours after birth. Of course, it can be done at a later stage also when it is no longer a newborn testing, newborn screening. It is actually to check the serious genetic, metabolic or hormonal conditions that are not visible at birth. And the purpose is actually early detection, so that you can plan the treatment and preventive interventions, etc. This is another area is fetal genetic screening, which is a non-invasive prenatal testing or cell-free DNA screening, where fragments of the fetus's DNA in the pregnant mother's blood, in order to determine the risk of genetic conditions in the child. So in certain situations there might be a necessity, and providing risk assessment, it is only providing a risk assessment, not just a definitive diagnosis, we must remember. There are other methods also in the first trimester testing, second trimester testing, etc. There are other different markers in the blood test also. Sometimes the issue comes that if one of the parent or both the parents, they have, or say one parent has, say, MEN1 syndrome or MEN2 syndrome, whether it is mandatory that you also order for fetal genetic screening. Whether you would ask for avoiding pregnancy, of course no. But then whether you will go for fetal genetic screening. So these are some of the ethical issues, but whatever we do, it should be absolutely left, the final decision lies with the parents. In medical practice or in medical research, the general ethics principle, which has been discussed already by my predecessor, these are the basic principles. There are different ways you can order them, but I feel that this, in Indian context, we should go by this order, whether basically there is a beneficence element. The beneficence element differs when you talk of individual patient care vis-a-vis when you talk of research. In individual patient care, beneficence is of course to the patient and his family, etc. But in research, the beneficence is actually for the future patients or the society. Okay, that must be very clear. In clinical research, in medical research, beneficence is not really directed to the patient. That is not the primary goal. The primary goal is actually benefit of the future patients. But we are expecting the patients will participate in research wherein they know that it's not directly targeted for their benefit. Okay, that has to be clearly mentioned. Of course, that doesn't mean that they will not receive the treatment. Their right to get treated is also retained. That has to be also explained. Non-maleficence is always important. We all know, do no harm. Autonomy is of great importance. It allows the respect, it allows to be respectful to the patient's dignity, self-determination, okay, well-being, and involve patient in deciding the treatment plan. So this is again very difficult. Involving patient in deciding treatment plan, very well said, and in Western literature, but in Indian context, it is a little, okay, tricky. All our patients will say, Dr. Saab, whatever you feel best, go ahead. Okay, how many of our average patients will understand the treatment plan and the purpose? But it becomes responsibility of the physician to explain actually. And finally, justice, to be fair and not be discriminative. These are some of the very basic ethical questions, okay, in reference to genetic testing. The first issue is whether it is really essential to order a genetic testing when you talk of care delivery, okay, that because in care it is basically for the benefit of that patient, but whether without doing the genetic testing we can provide optimum care to the patient, or genetic testing is extremely essential. That has to be established first. The physician must convince himself. Next, if genetic testing is preceded by comprehensive phenotyping, okay, comprehensive history taking, family history, okay, from the clinical presentation, whether the definitive diagnosis is becoming impossible. So this is important. And then would the genetic diagnosis be medically actionable? That again is very important. Just, of course, in research, in order to make it medically actionable, it might be justified. But in routine care, okay, if it is not medically actionable, that means the test is not going to help you to modify the treatment. Okay, perhaps there is no need to go ahead with the genetic testing because it's not going to benefit that particular patient. Should people be allowed to choose or refuse a test? Of course, yes, but then a proper informed consent is a must. Should it be mandatory as newborn screening? Maybe yes or no, depending on the situation, if it carries risk for the next progeny, etc. Should people be able to control access to the test results? This is again a big issue. Okay, there are differences of opinion whether the patient should be, I think in patient care, the patient has a right to get the test report. In research, many a times, it might not really help the patient, okay. If the patient is not knowing and it is not going to be much of concern, but there is some, in the report, there is some mention of some kind of risk, and you give that patient that report, then that carries unnecessary anxiety and this thing. So there might be some authorities say, not necessarily in all cases, in case of research, that you have to give back the report to the patient in order to avoid that. Finally, if the test results are released to third parties, whether it is employers or insurers, what precautions should be in place to ensure that people are not treated unfairly? First of all, whether it is to be shared with the third party. Forget about employer, insurer, insurance company. So we would expect that no, until unless there is a compelling situation, we need to avoid that sharing with a third party. Ethically, it is not sound. Now, coming to apart from the general principles of ethics that we have discussed, in patient care, this is also another way of looking at it, the care ethics principle. This is the four, again, elements: caring about, caregiving, taking care of, and caring for. That is attentiveness, competence of the person who is providing care, responsibility, and responsiveness. Attentiveness means recognizing the need, the family, understanding the family, the patient's context, dependency, literacy, diet, language, job and work schedule, cultural background, insurance. Caregiving or competence, providing evidence-informed, guidance-aligned, safe care, knowing the referral limits. So these are the responsibility of the physician providing care. So then you are becoming ethical. Responsibility, being responsible for the outcomes, taking ownership beyond prescription, and the onus to provide counseling, proper counseling. And responsiveness refers to following up impact of the care process in the recipient, closing the loop, inviting questions, monitoring adverse experiences, respecting patient goals, and modifying plans. So these are the broad care ethics principles which I think are to embed in our care delivery in a day-to-day practice. And I have coined this: to be at peace with genetic testing, the physician should consider these 5 elements. Peace is privacy, essentiality of the testing, autonomy of the patient, maintaining confidentiality, and equity, which actually justice, fairness. Essentiality is considering genetic testing only in the best interest of the individual and of science. Again, you have to prioritize. So individual concern should always prevail over science. Essentiality lies in the clinical need to diagnose current genetic condition on a given patient so that a precise therapy can be planned, or to predict future disease risk in the blood relations for effective prevention or treatment, or to inform family planning for inherited disorders. The factors to consider for essentiality: identifying symptomatic individuals, eliciting family history, considering availability of interventions, making reproductive planning, emotional considerations, ethics and informed consent, and counseling. So essentiality is extremely important. Now talking of autonomy, it refers to the patient's right to make informed decisions about undergoing genetic testing and receiving the results and acting upon that information free from coercion or undue influence. This principle requires genetic counselors. So again, in this kind of practice, I think institutional care delivery, now time has come that every hospital must have a post of clinical geneticist who will actually support and provide support to the clinician. It requires genetic counselors to facilitate patients' ability to understand complex genetic information, weigh the potential consequences, and making voluntary choices about health and lifestyle. And it is practiced through informed consent, as has been discussed in the previous presentation, voluntary decision making, non-directive counseling, considering the right to know, and relational autonomy. This concept is interesting. Instead of individualistic autonomy, we are shifting to relational autonomy, understanding the patient in his own, in his family, in his community, in his situation. So that is what is relational autonomy. It does not mean that autonomy of the relatives. No, relational autonomy is the autonomy of that person in his context. Coming to privacy, privacy is nothing but the right of the patient, right of the person to protect his individual genetic information or any personal information for that matter against unauthorized access, use and disclosure. It is a fundamental right of that patient which empowers individuals to make informed decisions, and it encompasses securing genetic testing, genomic sequencing, information regarding predispositions, as well as the ethical, legal, societal implications, LC they call it in the West. Confidentiality is uniqueness of the individual genetic information. Its familial nature bears significant implications on biological relatives, blood relatives, biological relatives who may be also have inherited genetic risk. There might be an ethical conflict between individual's right to confidentiality and the potential need to share information to the family members. Again, there is a dilemma here. Okay, there is a risk to the family member, but whether you are sharing that risk with the family member, keeping the primary person into the dark, that is not acceptable. But then if the primary person whose test has been conducted objects or does not like, so what to do then? Most of the authorities say no, because particularly geneticists will always say that they will be informing the family member who is also at risk. But then there is a dilemma here. So far as the act is concerned, in the United States, the HIPAA Act, what is there in India we have that DISHA, there is also GINA in the US. In India we have DISHA, and it is in the evolution stage, of course. Coming to equity, yes, fair and unbiased access, use of genomic knowledge. Of course, in the last say 10 years, 15 years, the accessibility has definitely increased, the cost has been reduced, and number of laboratories offering or providing these services has increased. So equity is gradually being established. Do we have a GINA like act in India? We do not have such act, but Supreme Court has ruled genetic information, genetic discrimination as unconstitutional, violating the fundamental rights to privacy and equality in Constitution articles. Such rulings establish protections against unfair treatment based on genetic information in employment, insurance and other areas. So we may say there exists a strong legal basis for upholding genetic privacy and equity in India too. These are the steps: detailed clinical workup of the patient, medical history including family history, phenotypic, non-genetic test guiding to genetic tests, and appreciating the need and rationale of testing, then genetic counseling, and then the genetic testing for the proband, that is the individual or the family members. These are the different indications for different genetic testing. And this is a very good practical guidance document. I have also given the reference. Okay, this is relatively recent, 2021. So very good summary, genetic testing in endocrinology. So interested people can go through and try to understand. Take home, genetic disorders have major and often lifelong impacts on the individual patient and on her or his family also. Mainstreaming genomics into clinical endocrinology is an additional tool to improve potential management with potential for downstream cost saving. Genetic testing can provide information about inheritance and identify at-risk family members to facilitate cascade family testing. The treating physician must weigh the risks and benefits of genetic testing and address all relevant ethical issues around essentiality, privacy, confidentiality, autonomy, beneficence, non-maleficence, equity, and justice. So we must uphold this. Thank you very much.
Thank you, Professor Tripathi, for your wonderful discussion. Now join question and answer session. We can take few questions from the audience. Yes. Got it. Right. Very, very important. And first of all, you started with retrospective and record-based. We must distinguish between these two. Not necessarily all record-based studies are retrospective, or all retrospective studies have to be record-based because you are going for old data. But record-based studies could be cross-sectional. Most of the time it is actually cross-sectional unless there is a research goal that I have to go for a timeline over the past few years, okay? And retrospective studies are longitudinal. Coming back to the informed consent. If you are considering all past records and you don't have any longer interface with the patient, okay, then of course there is no possibility that he will call. Just because of doing any research, you cannot think of calling a patient who was treated in your hospital 5 years back or 10 years back. Some of the patients might not be available either, okay. So I understand. I tell you, as Madam has already mentioned, that the situations where consent waiver, these are the situations where consent waiver is acceptable ethically. But again, the data that is being archived in your medical record section of the hospital, remember that hospital is not the owner of that data. Hospital is the custodian of the data. The doctor is the custodian of the data, not the owner. The owner is that patient who is not traceable now probably. So then you have to definitely take permission from the hospital, and you have to also ensure two things. One, data identity is to be undisclosed. Okay, when you are sharing that data with somebody else, that has to be undisclosed, de-identified. Okay, so that has to be, that is, you are actually respecting autonomy of that patient without even going for informed consent. Clear? So de-identification of the data and taking permission of the hospital that you will be using this data and mentioning for what purpose. So you have to also carry on that purpose and document all this. And when you are using photographs, you have to make sure that the de-identification process is also taken care of. Whether it is reports, pathology reports, radiology reports, or whatever, the patient's identity must not be disclosed. As simple as that. That's it. Thank you. Right. Of course. No, it will not suffice. In India today,
doing any clinical research, by rule, by regulation, you have to follow the regulation. That means you have to, any research has to be conducted under the supervision of an ethics committee. And that every ethics committee must be also registered with the government. Okay. Like if it is investigator initiated research or academic research, then the ethics committee must be registered with the Department of Health Research, Government of India. If it is new drug clinical trial, it has to be registered with CDSCO, okay, Drugs Controller General Office. So this is there, And anybody outside any institution, when he is planning to do a research, he should identify a nearby institute which is having an ethics committee and talk to them. And most of our institute ethics committee SOP also provides this provision or scope, okay, that Diamond Harbour Medical College. Let him come to Diamond Harbour Medical College, identify a collaborator in Diamond Harbour Medical College and do the research. Go ahead. Thank you.
I want to ask Professor Chatterjee, how to take care of these non-malfeasance in case of newer drug trial?
It is very difficult to answer this question. How to take care, nobody knows. Because when there is a new drug, that is... Okay, what is that?
Non-maleficence means do no harm.
No, how can we be so sure? That is what I'm saying. When you are dealing with a new molecule and you are doing a drug trial, so all the investigators are not sure what is going to come up. We have to ensure, we have to have all sorts of precautions taken so that any evidence that some kind of side effect is reliable to occur, then we need to stop that. So there are many examples in history where trials have been stopped when some side effects have come up. So that is the only way to take care. It is not so easy actually.
Asked about non-maleficence. What is that? Do no harm. Okay. Now, in order to avoid harm, your question is doing no harm to a research participant when you are dealing with a new drug. In order to avoid harm, truly speaking, you cannot eliminate harm. Forget about new drug, even in old drugs, okay, a drug which is in the market for last 50 years, that can also cause harm to your patient. Okay. But then it is the question of relative safety. So in order to eliminate harm or avoid harm, you need to understand the harm first and the probability of that harm to happen in a given patient. And that is what is called risk. Risk is defined as probability and magnitude of harm. Okay? Both are important. Probability and severity of the harm. That is risk. And there is also risk matrix, 5 into 5 risk matrix, lowest probability and highest probability, and the lowest severity and highest severity. So like that you can identify where does it stand, the probability of that harm to be happening to that given patient. That will again differ in the different phases of clinical trial. When you talk of a phase 1 clinical trial which is in healthy volunteers, then there is no benefit issue because this is a non-therapeutic trial. Okay, but risk is really huge because this is for the first time you are exposing healthy volunteers to, but then before that whatever research has been done, that is important. That whether in previous pre-clinical research, it has been shown that it is relatively safe to be considered for first human administration. Even then, in phase 1 clinical trials, you have to be extra vigilant. And that's why you find, okay, there are handful of phase 1 clinical trial centers in the country, not more than 7 or 8. Okay? While phase 2, phase 3 clinical trials, maybe 500 centers are there in the whole country. Okay? So that is because as you proceed, the possibility of risk is also getting reduced, but it is not totally eliminated. And even when it is marketed, the risk is still there. So there is a need, the routine care also you have to, all the time, every patient you have to also do risk assessment, risk benefit assessment, and then only you are justified. And there is a concept called clinical equipoise. But when you do a clinical trial, therapeutic trial, phase 2 or phase 3, you are actually comparing two treatments. One, the test treatment, experimental treatment against a standard of care treatment. Okay? So standard of care treatment, you are very confident. You are working with this standard of care treatment for years together. But then now you are exposing half of your patients. You are the clinician. You are only entitled to do clinical trial. And you are exposing half of your patients to a new drug, okay, experimental drug, about which you don't know really much. Had you known, you would not have done trial. You have treated all of them with the new drug. Okay, if it is better than the thing. So that is the reason you are doing trial. Now, there is a concept called clinical equipoise. That means a clinician come investigator must convince himself that both these two treatments, the standard of care and the experimental treatment, are equally poised insofar as the benefit and risk of the patient. If you can convince yourself, the moment you feel, no, new drug is better, you treat all the patients with new drug, or the reverse, that the standard of care is better than the new, you treat all your, because primarily you are committed to your patient. Okay, so it's a difficult area, but then you have to be clear about it, and you have to be transparent with your patient. Now the question is, madam has said that you take care that you don't talk too much about the harm. Okay, so that is probably from the angle of somebody who is trying to uphold the cause of research, etc. That yes, of course, we have to uphold, but the onus of upholding research is not only on the doctors. The onus of upholding research is to the society, and it is the duty of the investigator cum physician to also explain clearly that if we do not actually encourage participation in research, holding clinical trials, people will not get new drugs. So it is your choice there. So it becomes not necessarily only, it is the obligation of the right, it is the obligation of all people, of the society. Days are gone that Indians will only taste the fruit of innovative research in the West, and then that is not going to happen. If you want to get access to newer drugs, participate in research, contribute in development, and then you have to establish the right to get the new drug. Thank you. Wonderful discussion.
Thank you. One thing I just want to say, what sir has said is the ideal situation, what we should do. But sir, I would like to ask, what are we doing? What is the reality? That also is food for thought for the audience. Thank you.
But gradually we have to go to what is ideal. But
Yes.
then we just cannot say that it is impossible to do.
No, no, sir.
So
We should.
we have to educate ourselves. We have to create an environment which is positive for holding research. Okay, we have. How many of our institutes really have a policy for conducting clinical research in the institute? Do our health department has a policy for clinical research? Try to develop that. Talk to your DME, Director of Medical Education. Why can't we have a policy for conducting clinical research? Okay, because patients do not come to your hospital for research, participating in research. Patients are coming to get treatment. You take the advantage of getting them into research. So there should be a transparent policy that yes, research is absolutely essential. You cannot shy away with research any longer. Okay, so there must be a clear policy and transparent policy. Thank you.
Thank you all the speakers. Now the time's up. I am handing over the session to the organizer for next session. Once again, thank you both the speakers.
I thank both the speakers and the chairperson for this thought-provoking session. Next up, we have the next session on newer perspectives on diabetes, and I would like to invite the chairperson, Dr. Rajan Paul, upon stage to conduct the next session.
Thank you and good morning. We have a very exciting session now, only on the diabetes, on the topics which are less spoken in our common day-to-day seminars, and these are the topics we need to learn. And first we have Dr. Anish Ghosh with us. He will be speaking on very important new development related to the new pathophysiological pathway that can lead to future development of drugs. Over to you, sir. Dr. Anish is Director and Consultant in the Capstone Obesity and Diabetes Endocrine Science. Sir is Head of Endocrinology as well as in the Anthropology Hospital and Research Center. having numerous publications and has presented his original work in all international conferences.
My regards to the Bengal Endocrine Society and Endocrine Society of India for giving me this opportunity. So let's move from informed consent and ethics involved in genetic testings to a cutting edge frontier which is expected to open up new vistas in the management of type 2 diabetes mellitus. That is, let me introduce this topic to you. This is Inceptors, insulin inhibitory receptors in diabetes. These are indeed going to be a game changer if all goes well in the next 10 years or so. This is the overview. I will introduce you to Inceptors and their physiology. Then we are still in the nascent stage as far as research is concerned. We have not yet reached the phase 3 trials. We only have phase 2 trial data, and we will discuss that, whatever is available in the realm of science. We will also touch upon the applications before we summarize. So let us introduce the concept of Inceptors. So as you all know, when the system or physiology is met with hyperglycemia or glucotoxicity and lipotoxicity, there is a cascade of pathways involved in the activation of inflammation, which leads to oxidative stress and endoplasmic reticulum stress, which leads to the recruitment of epigenetic modifiers and also the regulation of translational and post-translational sequencing signaling, which in turn can lead to beta cell dedifferentiation and ultimately the loss of function and apoptosis of beta cells, which can lead to type 2 diabetes and its progression. We also know that insulin receptors are expressed in abundance in the beta cells, and beta cells in fact rely on the insulin signaling for its homeostatic functioning via autocrine and paracrine mechanisms. So this is very important. I'll come back to this point again and again, because the homeostatic functioning of beta cells of paramount importance for their holistic functioning and activity. So this is under threat when there is hyperglycemia and hyperlipidemia in the form of hypertriglyceridemia, leading to dysfunction of these homeostatic mechanisms, which ultimately leads to apoptosis and dysfunction of the beta cells. Why is it important? Now let us introduce the concept of Inceptors. Inceptors are, can you see this? No, I don't think the pointers are working. Can I have a pointer, please? Yeah. Inceptors are essentially transmembrane receptor protein 1, comes under this family of transmembrane receptor protein 1. Actually, these proteins have a cysteine-rich extracellular moiety, which closely resembles that of insulin receptors and IGF-1 receptors. They also have a mannose-6-phosphate receptor-rich extracellular domain, which gives it semblance to IGF-2 receptors. So in the nutshell, Inceptors are receptors under this family of transmembrane receptor proteins 1, and they have structural similarities, especially at the extracellular domain, with the insulin receptors, IGF-1 and IGF-2 receptors. What does it mean? Now, where is the role of inceptors in the physiology and later in the pathology of beta cell function? So actually inceptors can recruit this activator protein 2 adapter complex because they have an intracellular motif. Inceptors have an intracellular motif which can in fact activate, these inceptors can activate this activated protein 2 adapter complex which can come and combine with this moiety, and inceptors in turn can recruit these activated proteins to facilitate the internalization or rather neutralization of all these receptors, that is insulin receptor, IGF-1 and 2, and also facilitate their intravesicular transport. The intravesicular transport. So once they are from there, they are internalized with the help of inceptors upregulate the recruitment of activated protein into the clathrin-mediated internalization and intravesicular transport of these receptors into the sorting endosome and lysosomal system and eventually their degradation. So by doing so, they always have a check on the level of expression of insulin and IGF-1 receptors on any cells, including beta cells. So we all know that it is very important to shield the beta cells from getting overdriven by increased levels of insulin inside the beta cells and also increased expression of these receptors, because the more if the insulin receptor expression goes unchecked, or then there is a potential fallout in terms of, there will be less of sensitivity for beta cells to these receptors. So beta cells are in nutshell desensitized from these receptors by this important or critical mechanism. Then if you look down, there is another whole load of physiological function for inceptors. That is, inceptors deal with insulin and pro-insulins. How? Because inceptors functions like our mannose-6-phosphate receptors, because they have structural and similarity and they are located at the same places in the intracellular milieu. They can kind of shuttle cargo from the trans-Golgi network, between the trans-Golgi network, plasma membrane, and sorting endosome and lysosomes. And henceforth, they are actively involved in the processing of pro-insulins. I will come to that point a little later. So one side they can sort pro-insulins from into the secretory granules and helps in their maturation. The other side, over there, they can act as sorting receptors at the lysosomal system and enhance the degradation and removal of pro-insulins. What is the importance of it? We will look at it later on in my discourse. And that is, on your left side, you see the cartoon illustration of endoplasmic reticulum and trans-Golgi network, which is involved in the processing of pro-insulins and helps in their maturation. And at some point of time, these pro-insulins are actively parceled into vesicles and secreted into the cellular milieu. And where they can have either be converted into mature insulins and packed into the secretory ready to be secreted granules, or they can be taken into the endo-lysosomal system for eventual degradation. Who does that? That is the crux of, or one of the main role of inceptors. Whether to channel them into the right maturing pathway and pack them into the ready to be secreted granules, or take them, sort them to the endo-lysosomal system and finish them off. So that is also a major functioning of the inceptors. Down there on your right hand side, you can see the fluorescent immunoimaging showing the co-localization of inceptors in the trans-Golgi network, and also the transmission confirming that they are critically positioned at the subcellular level or in the electron microscopic level for executing this very critical function. So how does Inceptors handle proinsulins? There are either they can degrade by acting as at the lysosomal endosome lysosome system by executing their function as a sorting receptors. Also, it can sort proinsulin into secretory granules, as I said, and helps them into mature, ready to be secreted granules, because proinsulins can be actively converted into insulins, or remove unprocessed. So that is sorting by entry, or remove unprocessed proinsulins to control the secretory granule content. That is the molar ratio of insulin. So the molar ratio of insulin proinsulin granules or molecules in a mature secretory granule is controlled by Inceptors. So that is the importance of Inceptors. So that is sorting by exit. And this is what I said. Inceptors have a big role for recruiting activated proteins to bind to their intracellular motif and helps in the internalization and vesicular transport of these receptors to the lysosomal system or the Golgi apparatus, and eventually the removal of these receptors and their degradation. Henceforth, Inceptors have a critical role in shielding the beta cells from oversensitizing by or putting them into overdrive by the unchecked post-insulin receptor pathways, which will also affect the functioning of the beta cells. So they have a big role to play in the normal physiology. So in the nutshell, Inceptors act by internalizing insulin IGF-1 receptor, sorting proinsulins, and shuttling insulins and proinsulins. And so that is the physiological role. It's maintained the beta cell identity and prevents de-differentiation. That is the major role. In type 2 diabetes, but when Inceptors are overexpressed, when anything goes unchecked, it is going to create problems. So underexpressed, when it is expressed at right proportions, it maintains the sensitivity of the beta cells and also helps in the homeostatic functioning and signaling of the beta cells through autocrine and paracrine system or mechanisms. But overexpression is linked to reduced insulin sensitivity in the beta cells and also may contribute to beta cell dysfunction and glucose intolerance. How is that possible? These are the animal model studies showing, fluorescent tagged Inceptors moving from the nucleus or from the Golgi apparatus to the plasma membrane. Knockout mice models have given us some critical revelations like increased proliferation rate and mass of beta cells in the embryonic pancreas, increased levels of serum and pancreas insulin, significantly lower levels of fasting plasma glucose on 2nd to 5th day postpartum, and pups exhibited increased glucose tolerance. So knockout mice model studies are very encouraging. Knockout what? Knocking out the Inceptor genes. And this is tamoxifen enabled neutralization of Inceptors, again in mice models, have revealed that there is the blood glucose levels are lower in the knockout mice model, and the area under the glucose curve is far better in the knockout mice model. And also if you see the serum insulin levels are higher in the knockout mice cells, and beta cell mass is also higher in the knockout mice models. So reiterating the fact that this is indeed a potential therapeutic vista where we can explore in the future. Now they looked at the stem cell studies. They have immunopotent, pluripotent stem cell. They have differentiated them into either islet cell lines or C-peptide cherry receptor cell lines, and they made wild cell types and knockout cell types on either side. And that is the differentiation they are showing in the upper panel. And lower panel, you can see that the C-peptide levels in the C-peptide cherry receptor cell types are higher in the knockout models, and similarly, if you look at insulins and pro-insulins, are higher in the knockout models, reiterating that this is indeed a therapeutic option we should explore further. So stem cells have shown improved differentiation, survival and functioning of the beta cells in the absence of inceptors, suggesting that inceptors limit insulin availability by promoting their degradation. What are the applications? So we have these monoclonal antibodies. This is one therapeutic area which is progressing very rapidly in the field of science right now, in the field of research. So monoclonal antibodies against inceptors have thrown us very important insights into their role, and in fact monoclonal antibody treated cell lines have shown higher pro-insulins, higher insulins in the beta cells, and also higher, in fact lower pro-insulins to insulin ratio. So that is what is the implications and future directions. Inceptors inhibition may offer a novel approach to preserve beta cell function and mass in type 2 diabetes mellitus. In fact, these antibody-based therapies could be developed for targeted modulation. But we need, as I said, the research is still in the nascent state. We need further data and further research in this direction. To summarize, Inceptor is a key regulator of insulin and IGF-1 signaling in beta cells and in the CNS as well. Knockout and antibody-based inhibition enhance the beta cell function and glucose absorption, acts via receptor desensitization, as I mentioned earlier, and hormone degradation and granule turnover. Therapeutic targeting of inceptors definitely hold a bright prospect in the future management of type 2 diabetes mellitus. These are my references, and thank you so much.
Thank you, Dr. Anish, for the excellent presentation on this NEOA pathway. Please be seated here. Now we move on to our next topic related how these different treatment modalities can impact the quality of life in people living with diabetes. It's my pleasure to invite Dr. Manush Potumburia, sir. Sir is the director and head of the department in Department of Endocrinology in Apollo Excel Care Hospital. Sir has already in executive and research committee member in ESI from 2019 to 2022, and sir has been in the editor in different journals, peer-reviewed journals, both national and international. Over to you, sir.
Thank you so much, and it's time to move from ethics, basics, the bedside. So my talk is going to be very much bedside, very much practical actually, and I want to show you like what you actually perceive in a clinical practice may not always be true, and that so it is about the question of whether a particular modality of treatment, just oral versus injectables, can they influence the outcomes in a person with diabetes? So basically, I want to give you a background of the magnitude of a problem. Like we have got 600 million as per the IDF-21. This is huge numbers of living with diabetes in this world, and 1 in 10 adults walking on this planet is diabetic. That could be even more in India, and India and China is fighting, quite closely as to who is the diabetes capital of the world. So that's a huge problem. And when you talk about the quality of life in a person with diabetes, people with diabetes, like it's defined as how good or bad an individual feels their life is. That's a very basic description. And most crucial feature is to measure the quality of life in an individual with any chronic disease is by self-assessment, not by the secondary assessment like you ask, they answer. It's not, you should actually give them kind of a visual analog scale or a questionnaire in their language, a very simple language, and let them answer and then analyze. And it's not influencing that answering process or response process. And the studies on quality of life can provide actually inputs to the to improve the well-being of the patients and your your communication, like how you are going to communicate about a particular modality of treatment, and then these data can increase your confidence about a particular modality's outcome. And it actually contributes to the holistic care with very nominal extra financial burden. These kind of studies can be carried out without spending any extra money. You just have to have ethical clearance, and the patients, the study material is always around you. You just have to pick up a kind of protocol which is validated and distribute amongst the patients, and they will respond, and then you can calculate statistically what is outcome. So we actually looked at the DAWN quality of life protocol. So just to brief you about the DAWN, actually it's a very famous trial. The DAWN 1, actually it looked at a secondary assessment of quality of life of persons with diabetes as perceived by the healthcare provider. But DAWN 2, which came out later, a decade later, it actually a primary assessments as per a questionnaire, which is a self-response by the person with diabetes. It's not influenced by the practitioner, and that's what we used in our study. I'm going to describe my finding of a study which is already published in IJEM a couple of years back. So, and DAWN actually looked at the influence of family on the outcome, and there are a lot of publications, like 3-4 publications. You can go through them. So it's a triad of ACP, the person with diabetes, and family was instrumental in bettering the outcomes in diabetes management. That was outcome. Now, having known about quality of life and the particular protocol which we followed in our study, I want to ask you this question. Do you agree with the notion that insulin therapy is, as compared to oral drugs, are associated with poorer quality of life? I think most of us, we believe that insulin probably is bad, and that's a physician's barrier to start insulin. Keep aside the patient's barrier. We think that patients will not feel better. Their quality of life is going to go down. Maybe that's true for individual patients, and that individual patient should not define the type of practice you should have in your clinic. And we are always skewed to the odd finding. So that's why we should look at the statistics, the research outcomes. What does the statistics say? Let's look at this, on this hypothesis. So again, if you go back to the different studies which have been performed, there are a lot of them, but I'm just quoting a few good, well-conducted studies. Insulin was found to be better in some, like these 2 particular studies, and big multinational study in 2019 by Linjavi et al. Found that insulin was actually worse. So it's a conflicting result for insulin versus oral drugs in diabetes mellitus. So that's why we did this study of looking at the impact of anti-diabetic medications on quality of life in persons with type 2 diabetes mellitus. So what we did, we actually will briefly describe here. So the aim of the study was to assess and compare the DAWN quality of life scores in patients with type 2 diabetes on insulin with that of their counterpart on OAD. So insulin treated patients, they may be with or without oral drugs. So, and also try to examine other socioeconomic diabetes and biochemical parameters which are relevant for any patients who are coming to your patient clinic. And it was, a setting was an urban secondary referral clinic. That's our clinic, and we used 2 methods. One was primary, was a DAWN QL questionnaire, which was primarily responded by the patients or person with diabetes, and additional data collection were done from our electronic database, and that was a secondary data source, and it was as per the standard of care. We had 518 patients, male patients 1.6 to 1, that's a male-female ratio. Majority were from middle or higher income group. Educationally, majority were either secondary level or above. Insulin was given in 165 patients, at 56% were getting analog, and amongst the patients without insulin, 353 patients, 60% were getting sulfonylurea, which actually reflects what is being practiced in India. And this study was conducted between 2006 to 2016. The data collection was done during that period. And this is the baseline characteristic. I hope you can see it's a busy slide. So it talks about the age and the level of education, income, obesity was quite prevalent, as you can see here, both from the waist circumference. But there was no statistical significant difference between the two groups. So they're like well controlled in terms of various parameters. So this is the baseline. And this is these are biochemical parameters, but there are certain interesting facets to it. First, look at the glycemic control part. The insulin, patients on insulin were quite well controlled compared to their counterparts who were only on OADs. And you can see the HbA1c was very highly significantly different, lower in the insulin group. Even fasting and postprandial glucose were also better. Uric acid and EGFR were insignificant in terms of the difference between the two groups. But what is interesting to find here is that LDL-C and statin usage was significantly more in the insulin group. What does it reflect? It reflects probably three things. One, that patients on insulin were in an advanced state of disease, so they required statin. Two, it could be the physician who is giving insulin is more motivated to give the proper standard of care. That's why they introduced statin. And three, probably the patients were more motivated to take other medications which are beneficial to them because they are already on something, insulin. That's an extra effort they have given to, improve their, health outcomes. So probably statin, which is very essential for diabetic, as you know. So also was seen to be more, taken more in case of the patients with insulin, patients on the insulin cohort. So that's one thing we must remember, that once you win that game of giving insulin, probably other games become easier. So that's one message I want to give. And this is very unique, simple assessment tool we use is termed as DEMIM. We have published about this. This is a scoring system which is done by the counselor or dietitian, where the score 1 is given to those patients who know insufficiently and executes inadequately, and the highest score is 3, that is knows sufficiently, executes inadequately. In between there is a score 2. This is different from the Dawn score, but just to brief you here, in this particular simple scoring system we found that patients who were on insulin, you can see here, had a better score, which is statistically significant in our analysis, for a diet, but not for exercise. Exercise, it was not much different. So it was seen by this scoring system that patients were more motivated to comply with the dietary advices if the patient is on insulin. Apart from that, severe hypoglycemia was actually slightly more in case of insulin patients on insulin. That's expected. And coronary disease, of course, this you cannot actually have a conclusion regarding this. Again, it was slightly more in case of insulin patients on insulin, because that may signify that patient had an advanced state of disease. Obviously, the complication would come. As I have already mentioned, EGFR was not different, so that way we cannot conclude. And this study was not powered to look at all those complication issues also. Cancer was not more prevalent. It was not statistically significant in both the groups. That may be of some interest to all of us, because we thought that insulin could be, at that time at least, insulin was blamed to be a pro-cancerogenic agent, but now we are not knowing that it's not so. Now coming to the main point, this is a Dawn KOL assessment score, which talks about diet, exercise, taking medication as prescribed, testing yourself, that is self-testing, and keeping appointments with the healthcare professional, this doctor's appointment. So you can give a score of 6 or 1. 1 is do not know or refuse to answer. In between there are scores of 2, 3, 4, 5, 6. So when it is complete, it is 6. So let us look at what are the findings. So for diet, again, it was statistically significant in case of insulin cohort who performed better. For exercise, it was insignificant, no change. Taking medicine on time, that is that drug compliance, insulin again was statistically better. Testing, it was not significantly different. For making appointments with the doctors, that is coming to the patients, or compliance in terms of clinic visits or follow-up, was again significantly better with insulin. And overall, the score, although the overall score was not so significant, it's a borderline significance, 0.06 p-value, because the study could have been bit, less in numbers in terms of having adequate power to answer this question. So nevertheless, these particular points were very important that showed that insulin is not bad, in fact it is better for our patient for this particular criteria. The limitation, of course, is a cross-sectional study, not adequately powered to answer this kind of question probably, and the questionnaires were filled up in the clinic, so patient may have been influenced by the clinic environment not to hurt us by saying something which may be actually in their mind, but we didn't influence their response process. We are not supervising. They were allowed enough time, like 30-40 minutes with the perform-up card to respond to it. Despite this limitation, our findings are robust representation of the prevailing real-world scenario, which actually can guide our practice. So there are similar studies. I'll just briefly talk about these few studies, a couple of studies. This particular study, nice study from India itself. It's a busy slide. They used another scale like WHO BREFQL questionnaire and compared between oral hypoglycemic group and insulin group. And in summary, what they found that physical domain was significantly higher amongst oral hypoglycemic group, because if your patient is taking injection, the physical well-being part is gone, because the patient has to endure that pain part and all, and these things. So that's injection is a great denominator for this whole physical domain. But psychological and social domain were better with insulin, because insulin gave them better glycemic control and better confidence, and that made their psychological and social life better. So this is very important message, similar message coming from this. This is another study, probably it's a Turkish study, which examined using European QL questionnaire system. They found that in terms of mobility and self-care, insulin versus OAD are not different. But interestingly, if you look at the usual work, the day-to-day work, whether they were able to perform the usual work, here insulin was better. Again, if you look at pain and discomfort, as expected, insulin is worse. But in terms of anxiety and depression, insulin was quite significantly better. Insulin brought down their anxiety in the long run. And overall score, again, insulin was better. Visual analog scale also was better. So overall, the insulin had a very favorable result in this particular study. And lastly, in terms of knowledge score, insulin was significantly better. That means a patient who is on insulin knows his disease better, and knowing the disease better is always important for facing, at least in case of chronic disease, it's very important that they face the outcomes of the disease in a positive way and try to overcome various limitations which is due to the study, disease itself. So there are a lot of points in favor of insulin from various studies across the globe, and I think, just to conclude, the person with diabetes who are on insulin with or without concomitant OADs had better quality of life owing to better lifestyle-related knowledge, attitude and practice, and superior treatment adherence compared to their counterpart using oral drugs alone. And this is seen despite the age of the individuals being more, and duration of the diabetes being significantly higher amongst the former group, that is the patient taking insulin. And such findings should actually dispel the myths surrounding the patient's lack of acceptance of insulin therapy, and that should actually encourage timely insulination. And this is a lesson for us clinicians to know that probably patients' initial barrier can be overcome by proper counseling and this kind of research findings, which is very important in our clinical practice. Thank you very much.
We are going to our next talk related to the diabetes distress. So this is very important from the patient point of view, and it's my privilege to invite Dr. Tejal Lethia from Navi Mumbai. Ma'am is now in Apollo Hospital and the Hormone and Bone Center in Navi Mumbai. Ma'am has more than 50 peer-reviewed publication, and her recent works mostly on the how we should talk and communicate to the patient so that we can decrease their stress. Over to you, ma'am.
Thank you so much. And Dr. Barua, excellent talk, which ties in a lot with my talk as well. And my talk is diabetes distress, the concerns and struggles regarding diabetes distress. So this is the team which works with me, and we have had these publications where 2 of them are psychologists, and then Dr. Chitra Selvan, who's an endocrinologist, and myself. And the flow of the talk is, why is diabetes distress a concern? Why should we even think about it in our clinical practice? This is something which makes me quite unpopular with people, is the intersection of healthcare practice and diabetes distress, and how we as doctors sometimes contribute to diabetes distress. So none of us like to be told that, but it is true. And the struggle to identify and manage diabetes distress. So first of all, why is diabetes distress a concern? And as doctors, what we love is data. And the data says that there is a lot of diabetes distress, not only worldwide, with the frequency in the worldwide studies ranging anywhere up to 65% of all people with diabetes entering your clinic are suffering diabetes distress. There are a lot of Indian data as well, which is roughly from the tune of 18% to one study in rural Amritsar, where 100% of the people who entered the clinic had diabetes distress. And what I would also like you to note is many of these studies are very recent. They all are 23, 24. So that's extremely important to understand. And if I put the data very simply, how common is diabetes distress? This is the MILES-2 study from Australia. 1 in 4 people with type 1 diabetes, 1 in 5 people with type 2 diabetes, and 1 in 10 if they're not using insulin. So having insulin on board makes people more prone to develop diabetes distress, and if they're only on oral hypoglycemic agents, then the diabetes distress is less. But why should we be concerned as a clinician sitting in the clinic? The reason being that the most important impact of diabetes distress is suboptimal diabetes self-management. When we say self-management, it means ability to maintain exercise, ability to keep a healthy diet, to check blood sugars frequently, go back to see the doctor. So these are very important, and there is a direct effect of diabetes distress on the ability of a person to undertake self-management of their diabetes. And then what happens? Obviously, there are going to be higher HbA1cs, there's going to be more hypoglycemia. This also causes impaired emotional well-being and obviously reduced work and life productivity. And if a person is ill and works less, their life is less productive, they are more distressed, and that's going to worsen their diabetes as well. So I think we as doctors have a lot of investment in understanding about diabetes distress, because allaying diabetes distress, improving diabetes distress will have a direct impact on better outcomes for our patients. And this is why I put this traditional approach. The traditional approach is what we are taught in MBBS: history, investigation, diagnosis, treatment, write a prescription and give it to the patient. And that is what we all have been doing all these years. Correct? So this is a simple way. Type 2 diabetes, good diagnosis, good treatment will directly translate into less complications, better HbA1c, and better quality of life. However, obviously, in spite of all the advances we have in sensors, insulin pumps, GLP-1 analogs, tirzepatide, what is happening is still most people who come to our clinic have an HbA1c which is more than 7%. Barely 20% of people are achieving an HbA1c less than 7%. So what does that mean? So are we missing something? Is there a step somewhere between making the diagnosis and treatment and getting less complications and quality, having better quality of life? I think the missing link is suboptimal self-management of diabetes. It's poor adherence to treatment with people going on and off treatment frequently. And one very important thing which most of us don't realize is disengagement with healthcare. So many times people will come into the clinic, I have not seen a doctor for 2 years. And what do? Our reflex response is we shout at the patient and say, why didn't you come? You're so careless. You should go properly to the doctor. What we fail to understand is what is the level of distress they have, what has been their experience with the last doctor, how was the communication with the last doctor, and why is it that the person didn't come back. So now as a practice, whenever anybody tells me that I haven't seen a doctor in 2 years, the first question I ask is, then why is it that you don't go back to see a doctor? Did you have a negative experience? Or what was the experience you had which made you decide not to go back to the doctor? So sometimes it could be because of the doctor's communication, it could be because of financial constraints. So many times patients will say, my mother died, my father died, my husband died. And what we have to remember as doctors is that diabetes is not the only thing in their lives. And there's a big life that they have in which diabetes is a small part. So I think that somewhere the missing link could possibly be diabetes distress, and allaying diabetes distress will lead to better self-management, better adherence to treatment, better follow-up with the doctor, which hopefully then will translate into better HbA1c, less complications, and better quality of life. So what is diabetes distress? So this is what is psychological distress, demoralization and pessimism towards the future. What's the point? We're all going to die anyway. What's the point of taking care of my diabetes? I've been doing it for 25 years. I don't care anymore whether I live or die. This is very, very common. We've all heard these comments in our clinic. Anguish and stress, feeling stressed about exercise, stressed about diet, feeling stressed about doing blood sugars again and again, stress about reporting to the doctor. Social withdrawal and isolation. They stop going out to functions. They stop interacting with friends. They remain constricted to the home. Somatization. My leg is paining, my body is paining, my head is paining. So many times we come with these patients with unexplained body pain, right? And we don't know what to give them. So we throw magnesium, B12, vitamin D. The B12 is now 2000, the vitamin D is 100, but they're still complaining of body pain. So somatization can be a significant indicator of distress and withdrawal into oneself. The patient comes, sits in front of you, you ask the question, they will give one-word answer, you'll give the prescription, they leave the clinic. And you're wondering, why is this patient not listening to me? Why is he not interested in his diabetes? So it could be because they're extremely distressed and they really see no point in talking about their diabetes. So what is diabetes distress? It's the direct emotional distress of living with a chronic condition which will never leave them for the whole life. The burden of self-management, having to watch what they eat every single day, every single meal of their life. And the prospect of long-term complications. What if I get a heart attack? What if my kidneys fail? What if I become blind? Now, emotional distress, diabetes distress has 4 components: emotional burden of diabetes, interpersonal distress, regimen distress, and physician-related distress. Of course, there are other reasons for distress: social impact, financial constraints. Type 1 diabetics, mainly insulin and hypoglycemia is a cause for concern. For type 2 diabetes, the obesity and restriction of food is the cause of distress. But if we go a little deeper into these 4, we'll come to physician-related distress. Feeling that my doctor doesn't know enough about my diabetes and doesn't care about my diabetes. Feel that my doctor doesn't give me clear enough instructions about how to manage my diabetes. My doctor doesn't take my concerns seriously enough. And I don't feel that I have a doctor who I can regularly see for my diabetes. So could diabetes distress and the fact that doctors are not aware of diabetes distress somewhere be the missing link to better outcomes? So the questions I will leave with you in this section is, if we know that diabetes distress exists and we know it impacts outcome, how come we aren't paying attention? Can the experience of the condition be greater or possibly more important than the actual diagnosis and treatment? And does the failure to factor in this diabetes distress somewhere be the missing reason why patients are unhappy with us and don't come to us and often seek alternative care? So difficult questions to which I have no answers, but I urge all of you to reflect. So where does healthcare practice and diabetes distress interlink? So people with diabetes already are struggling with fear, worry, and guilt, and they already know that diabetes causes complications and they can lead to death and it needs attention. So if any of us think that the person sitting in front of you does not understand that, that's not true. They all know that. But unfortunately, what we do, and this is data which Dr. Chitra and I published in 2023, is about how we talk to the patient and how this impacts diabetes adherence. And what we end up doing to patients is exactly the same. We speak in a way which is authoritative. It is authoritarian. We tell them, take your money back, and this is real data, which I'm not making up. You can take your money back. If you don't take your medicines, then I'm not responsible for your health. Why have you come back after so long? And if you don't want to listen to me, please don't come back. And I am guilty of having said the same to patients. So this is data from a study that we did. And what we also do is add to the fear, blame, and threats that the patients are already experiencing. So when I put in that slide, patients with diabetes are already going through fear, worry, and guilt. And what we're doing by the way we communicate is increasing the fear, blame, and threatening them, which makes them feel even worse. And I hate this data because it makes me feel really bad about myself. But then we went on to do a little bit more research. And again, the same theme reflected, that there's a plethora of negative feelings that a person experiences because of the physician's verbal and non-verbal communication style, and they have specific expectations from the consultation, which often we are not able to meet. So I will not make you feel worse, but this is some of the data that we have of patients who have spoken things to them about, treat me like an adult, the doctor's language implies that he's superior to me, before I open my mouth, the prescription is ready, and etc., etc. But this is a great line. This is a patient who saw me for years. He said there is a therapeutic use, and this is the patient's own language, I haven't made it up, therapeutic use of effective communication which creates a trustworthy and healthy relationship with the patient. And apart from medicines, you need to enhance our willpower, and this happens when the doctor talks nicely to you, and that also has a therapeutic impact of the disease. So I feel I can close the talk here, but unfortunately I have more slides. So the questions I'm asking you is, how do we contribute to diabetes distress? Nobody is doubting the intentions that we have. Yes, we care for the best of our patients, but the way we are justifying that intention, is it appropriate? Is it time for dedicated training in communication in the context of chronic illnesses like diabetes? So the last couple of minutes, how do you identify diabetes distress in the clinic and how do you manage it? All of us run very busy clinics. We see about 50 to 100 patients a day. We don't have time to run questionnaires in the clinic. So what else can we do? So we have one more box to tick. And my question was that if you can't screen every patient for diabetes distress, what can you do? And if the person is distressed, what do I do? So this is, maybe I will not go through all these because of paucity of time. I'll just give you this one patient. So it's a 62-year-old male living with diabetes for 22 years. He's on insulin twice a day. His HbA1c is 9%. You tell him take a GLP-1 analog. Liraglutide is really cheap now. He doesn't want to take it. You tell him to go on basal bolus insulin. He doesn't want to do it. He skips his dose. Afternoon dose, madam, I don't have time. If you ask him to check his blood sugars, he says, I will not do it. It's very painful. Sensor lagao, it's too expensive. Khana, I'm already doing everything perfectly. Please don't give me gyan about food. Exercise, I'm doing as much as I can. I can't change anything. His wife is not allowed to come for the consultation because she complains about him, right? So what are the words we are using in our mind when this patient is sitting in front of us? This is an unmotivated, non-compliant, difficult patient. He is passive, he's aggressive, he's belligerent, and he's a waste of my time. But this is somebody who is deeply distressed because of their diabetes. They've been living it for 22 years, and they're just sick and tired of managing their diabetes. So what does diabetes distress look like? When does it peak? So the greatest peak comes at the time of diagnosis, and often patients spend 5 years accepting the diagnosis of diabetes, adding a new medication or insulin, diagnosis of a complication, hospital admission, significant life event, especially if you hear them well, the death of a parent because of diabetes-related complications, financial stressors, professional transition, and what that person who I just talked about had, diabetes burnout. So he's burnt out managing his diabetes and he just doesn't care anymore. So what are the red flags? Risk-taking behavior. The wife will complain, इनको पता है diabetes है, फिर भी 4 रसगुल्ले खाते हैं. Because he's like, to hell with you, I'm just going to do whatever I like. Unhealthy eating, missing doses, not checking sugars. Very, very important, not attending clinic appointments, not coming for the appointment, and when they come, they look like they're doing you a favor, right? We all know those patients, right? Who just come, you speak, and they leave. So these are the people who are likely to be distressed, who have troubled relationships not only with healthcare practitioners but with their family and friends, and they use emotional eating, smoking, and alcohol to cope with the distress. One last point I wanted to make is often we think if somebody has an HbA1c which is 6.5, that means they don't have diabetes distress. But please remember that sometimes maintaining that HbA1c of 6.5 and the effort it takes to maintain that 6.5 can cause a huge amount of diabetes distress to somebody, and a good HbA1c does not necessarily mean that the person is okay with their diabetes. So that's also a point we would like you to keep in mind. So what do we do? So the ADA has lots of suggestions for what to do, but the simple thing that I could ask you to do, if this one slide can be my last slide, is acknowledge that managing diabetes is hard, acknowledge that having diabetes is hard. It's not an easy disease to have, it's for the rest of your life. Normalize negative emotions. So if they're angry and upset about the fact that they have diabetes, you can normalize and say, I understand that this must be really difficult for you, especially because your parents have diabetes, or you've seen your parents take insulin, or that your father had a heart attack. Shift from personal responsibility. Because you didn't do the diet, the HbA1c is high. Because you didn't exercise, the HbA1c is high. Do we all know patients who are doing everything in their power and yet struggling to get an HbA1c below 7? Yes, we all have these patients. And counterbalance with what is going right. So this is one thing that I've started doing in my clinic over the past maybe 6 months to 1 year. So when the patient sits in front of me and says his HbA1c is 9%, I first look for things that they're doing right. you're taking your medications regularly, you're exercising 3 days a week, you're trying to eat healthy most of the time. So that's really good. The HbA1c was 10% last time, this time it's 9. We are moving in the right direction. And then maybe you could go a little bit more into detail of what you can do better in terms of treatment, what they could do better in terms of exercise and diet. So these 4 things, acknowledging that it is hard, normalizing the negative emotions, shifting from personal responsibility, and counterbalance with what is going right. So you could simply take statements like, I can understand how difficult and frustrating managing diabetes is. When both your parents have diabetes, it is difficult to avoid diabetes, which is why probably you've developed diabetes at a young age. So this shifts it from the personal responsibility. You could use the help of a psychologist, and maybe you could give them a slightly higher HbA1c goal, be a little kinder, ask family members to support them more. These are the small things that you can do in the clinic. So there's a lot of data around this, and this is my last slide. The translation of science into practice, the human element is indispensable, and until and unless we acknowledge the person sitting in front of us and the struggle that they have with their diabetes, the best prescription, even tirzepatide 15 milligram weekly, is not going to solve the problem and is not going to help them manage their diabetes better. Thank you so much.
Thank you, Dr. Biedl, for such an eye-opening talk. And you can sit and you can take, please come and sit in the dais. And you teach us like how much sensitive we should be while we are talking to our patient and how it can impact in the therapeutics. Now the session is open for question and answer, and we can have questions from audience for all the 3 of us speakers.
For you, that the Inceptors are treating the immature insulins because of the misfolding or any other kinds of actions.
No, actually, inceptors are not distractors. Inceptors are just guiding. They just closely monitor the trafficking of pro-insulins and insulins, and they look at the cheaters, the one which is jumping the red light, and they just eliminate them. So they are supervisors. They look at how pro-insulins are going through the trans-Golgi network into the secretory granules, maturing into insulin containing granules, and at appropriate time in a glucose dependent manner they are secreted into the bloodstream. They are just looking at wardening this process, and as and when they see rogue elements, that is pro-insulins which are persistently not channelizing into this right track, they are staying out of this track, they are removed, eliminated, and misfolded insulins are eliminated. How do they eliminate? They just track them, channel them into the endolysosomal system and act as receptors, they're sorting receptors there in the endolysosomal systems, and helps to degrade them and remove them from the system. That is how they act. They don't destroy.
My question to Tejal ma'am, like these negative emotions like fear, scolding, they are not always bad. I do agree with you, like like we need to talk to them very sensitively and with empathy and kindness. That is, I'm not disagreeing with you. But sometimes, suppose we say very simple thing that if you can't control your blood glucose level, you will develop a features of micro and macrovascular complications. So this, in an other hand, we are instilling some amount of fear to the patient. So what is your take? Is it right or wrong? Some patient is coming to me, and if
Sentence I once told a patient, and please don't judge me for this, but I thought I was doing what was right for the patient. I told him, you choose which toe you want to cut, because looking at your HbA1c, I think you're going to end up with an amputation. These are words that I have used for a patient, and my intentions were for the best. So Weber was trained with me, and he knows what kind of doctor I am, but these are the words I used for a patient. And for the longest time, I thought that I was doing right. It's only when we began the research, Dr. Balui, the patient never came back, I'm sure. If I was the patient, I would have never gone back to that doctor. Never, ever, right? But anyway, I don't know what happened, because that's the thing. We don't know what our patients are really feeling. And when Dr. Chitra and I did the first study, so we have recordings of hours and hours of focus group discussion. The first time we both heard the recording, we were devastated. We had no clue the kind of trauma we were inflicting on our patients. You have no clue. So the thing is that we are doing right according to us, and we have been taught in medical college कि आप complications के बारे में सिखाओ तो ही वो सीखेगा और diabetes control करेगा. But so let me just complete. And I know I've been in that chair and I have been in that seat for the longest time before the data changed me, right? And we are scientists, so we're not talking about feelings and emotions and my hallucinations, but this is the data and I can show you all the data. What I would suggest is that fear and hope are two emotions that you can offer a person, and hope always trumps fear. So the same thing that you want to communicate, if you could put it like this, that Mr. So-and-so, if your diabetes is better managed, we can avoid kidney complications, we can protect your kidneys, we can protect your eyes, and you can have a better quality of life. The same thing I can say that अगर आप diabetes control नहीं करोगे तो आपकी kidney खराब हो जाएगी, आप अंधे हो जाओगे, या आपको amputation हो जाएगा. So in the second sentence, I am giving a life sentence to that patient. I am putting the blame on that patient that he alone is responsible for the management of their diabetes, and I'm taking away all hope from this patient. So many times, if you really analyze your clinic, so sometimes we say these things to the patient. Now what will happen is you have said it to 10 people. One person came back. So you think it works. But the 9 people who didn't come back, you don't know that they didn't come back. So you don't know what your words did to them. And I should not say your words, our words, because I have used all these words, all these phrases, all these sentences to people for decades until the recording of that focus group discussion, and you will not believe it, I have actually called a couple of patients and apologized to them. And this Chitra always shares in all the talks. So we had selected patients who are our good patients, जो long term follow up में आ रहे थे. हमको लगा we're doing a great job with this patient, right? हमको ऐसे लगा ये हमारे best patients हैं, इसलिए तो बुलाया ना, because we thought they will give us good review. And they all had horrible stories to tell, not only about us, but the doctors they'd seen in the past. And that was the turning point for us, and which is why we continue to study this. And the next study that we're doing, if Dr. Chitra allows me to share a little, is about diabetes stigma. And what we discovered, and we were horrified to discover this, I never knew that this existed. The diagnosis of diabetes, that is the most important point in our interaction with the doctor. And when a person used to ask me कि मुझे diabetes क्यों हुआ, and these are the sentences I used to say, वो ना अभी हो गया ना, अभी उसका क्या करने का, आप आगे देखो ना, हम उसको अच्छे से मैनेज करेंगे. But the patient gets stuck that why did I get diabetes, and they spend often up to a decade still stuck at मुझे diabetes क्यों हुआ. You give them the best medicine, you give them GLP, you put them on a pump, the HbA1c will still be 10%. So until they can move past that point of मुझे diabetes क्यों हुआ, they remain stuck there. And this is something I had never imagined could be important to a patient. But when the data came out, and this didn't happen in one interview, first interview, second interview, third interview, every patient kept saying the same thing. The doctor did not give me a reasonable answer for my diagnosis of diabetes. I don't know why I got diabetes, and if I don't know why I got it, I don't want to even think about it. So your point is well acknowledged. I have been that person for many, many years. I continue to still be rude to patients occasionally on a day when I'm really tired, when there are a lot of patients. I am, emotionally exhausted, but hope trumps fear, and saying the same thing but in a slightly different manner can be a complete game changer for the patient.
Just to add, as a corollary to what she said, I think Dr. Chitra and Dr. Tejala are quite passionate about this topic, because I've listened to Dr. Chitra also, similarly I think in Mysore, and I've seen the passion and the spark then as well. Having said that, you both always hammer on the human element involved in the other side of the table. There is a person sitting on this side of the table as well. Now the corporatization of hospitals has taken place. Equity huge equity conglomerates are taking over the hospitals. They're putting enormous pressure on doctors. At the end of the day, they are not looking how much quality of life have you improved, how much you earned for us. Because it is sheer markets are involved in controlling the health sector, and doctors are given targets, because when you are given a hefty paycheck, you are given additional response to fetch money, not only for your salary, but for the hospital as well. So, and also, the person who is sitting here has a lot of expectation from the management, a lot of expectation from the patients, and on a best day, you can tackle it. You can tackle both the load of expectation from the hospital management and the lot of expectation from the patients. On a worst day, every one of you have a worst day. Are you all on a roller coaster every day? No. Someday you come with a kind of a forgettable day from home, and you're sitting there. Imagine a day, and on your way into your office, one of the manager in the corporate sector has given you a nudge on the performance of yours, and the first patient whom you see comes there, sit there and download on you. How would you take it? I think it is high time that we should start addressing the person who is sitting on this side of the table as well.
So can I just respond to that? It's a great point, sir. It's a great point. And this was the topic which we addressed about 2 years ago in the We Care conference, in a session that was designed for evolving or development of endocrinologists per se. So the theme of that talk,
and also a third person is now facing a lawsuit, litigation. Kerala, it is rampant.
Yeah.
Couple of my friends are facing it, and half of your life would go there.
Correct.
So defensive practice is a big thing now.
Correct.
I don't know. Please. So you're just, jettisoning your responsibility. First thing is to defend yourself. I think in Kerala now, huge nexus is going on patient advocates. So we first defend ourselves.
So Brené Brown is a psychologist who's researching vulnerability, and her statement is, you can only be kind to another person as much as you can be kind to yourself. So I think this is an extremely important point. We can only be nice and kind to our patients if we are being nice and kind to ourselves in our head, which means, are we sleeping well? Are we overworking? Are we negotiating our fees enough? Have we left the corporate job where it's time for us to leave? Have we charged enough prices for the value that you bring to the conversation? Have you negotiated your salary adequately? Have you taken care of your needs first? And then we go on to do greater good for the world. So I'm glad that you asked that question.
In a corporate sector, can we meet all these expectations?
It's a choice, sir. Everything in life is a choice. I think that's the first realization.
No. If you as a group you are approaching the whole matter, then corporates cannot beat us. They need us.
All this is 50 to 90 patients are your wish, or it is being thrusted on you? That is the question.
So if you set up a center and charge 2,000 rupees, I'm sure you will still have patients who will come to see you, and you will still probably make more money than you're making at the corporate setup. Tejal is the setup for that.
I have stopped seeing 60 to 90 patients. I see only 30 patients a day, 9 to 5, Monday to Friday. I'm earning well. And I hope you're going to.
Just one line, one sentence. This is because time is up. So in reference to your patient, that amputation patient, I think the conversation can be positive. I give an example. The person is coming with diabetic foot ulcer, bad gangrene. So I can tell him that I want to see you healthy, walking with your granddaughter in 2050. If you do not do that, probably that moment will not come to your life. So start with a positive note, but the message is same. I do that actually. And many times we forget that silence is more important than the words. Sometimes you have to offer silence. The person is talking about some tragic incident in the life, and that has brought up the blood sugar. That's a extreme distress. You come, if you ask, you find that there are a lot of stories to each patient who are actually troubling the receptionist outside, may actually be having something happening in your family. So you ask, to the extent you should know, not to the level a psychologist would ask. Then sometimes I just offer silence. I just touch and offer the silence that works. A patient may cry also, and you allow them to cry. that is extra 2 minutes. But actually that wins the patient's confidence for the entire life. That works. Offering the silence.
2 words of wisdom, sir. Thank you all. Thank you all for the excellent session, and I will hand over for the next session to the organizer.
I thank the speakers as well as the chairperson for that excellent session. Next up, I invite Dr. Kaushik Sen and Dr. Vijay Budwar as the chairpersons for the next session titled Hidden Hormones and Hurting Nerves, Pitfalls in Type 2 Diabetes Care.
After an insightful session, we shall be moving to the next session, which is this one, no? Right. So from ominous octet to noxious 9, as said by Dr. Ralph DiFronzo. So Dr. Kalpana Das ma'am, she will be enlightening us on the hypercortisolemia in type 2 diabetes mellitus.
Good afternoon to you all. Thank you Eshikon 25 for having me here. I have been assigned to talk on hidden hypercortisolism and type 2 diabetes mellitus. So my outline will be like this, from background to take home message. So first of all, I would like to know there are lots of studies that have come up in the recent past. So the studies, they talk about when to suspect hidden hypercortisolism and what are the clinical presentation and what is the magnitude of problem. So let me define what is hidden hypercortisolism, or we call it as subclinical hypercortisolism. That is basically defined as a biochemical cortisol excess and without the telltale signs of Cushing syndrome, yet there are biochemical testing which reveals autonomous cortisol secretion. So this is identified in a subset of diabetic patients, those who are very difficult to treat, and they're having significant metabolic complications that includes difficult to treat diabetes, uncontrolled hypertension, even osteoporosis with fragility fractures. And mostly it is because of the autonomous cortisol secretion, that is because of the adrenal incidentalomas. And the prevalence varies from 5 to 30%. Among type 2 diabetes mellitus is 5 to 12%, and higher rates among those who are having poor diabetes control. So you can see here the prevalence of this entity. So those who are having diabetes and incidentaloma, they are having the higher prevalence. Then I will discuss 3 cases, very important cases, which has question about what is the cause and what are the clinical presentations and what is the magnitude of problem. So we have a case of 62-year-old, morbidly obese, long duration type 2 diabetes mellitus, having hypertension, hyperlipidemia, CAD and OSA, already on CPAP, and already on maximum dose of antidiabetic requiring 300 units of insulin, tirzepatide at a dose of 10 milligram weekly and maximum dose of metformin. And patient has weight of 130, having hypertension, and the recent freestyle Libre CGM download that has demonstrated TIR only 17% and the TIR 26 to 57%, and there is no TBR, and GMI estimate is about 10 to 20%. So what is there in this case? Despite taking so much of tirzepatide, he kept on increasing his weight, and which was highly unusual, and that actually struck to me that I should rule out the Cushing syndrome. So out of curiosity, I just did one overnight dex suppression test, and the cortisol was non-suppressed. Then further evaluation demonstrated that patient is having Cushing's disease, and MRI pituitary also that confirmed that, and surgical intervention had settled all the biochemical and the physical parameters of this patient. And the second case is a 56-year-old, again diabetic patient having significant hypertension, that is severe hypertension, severe hyperglycemia, and patient presented with fatigue and weight gain. He has severe hypertension and hyperglycemia, and in this case also the hormonal evaluation again demonstrated has cortisol excess, having ACTH low and low dose overnight X suppression test, cortisol non-suppressed, and adrenal mass was there on imaging, and the diagnosis of adrenal incidentaloma was made with mild autonomous cortisol system secretion. So diagnosing as a hidden hypercortisolemia in the setting of type 2 diabetes mellitus with severe resistant hypertension. So the management outcome in this patient, when given the worsening metabolic profile and laparoscopic left adrenalectomy was done, after that the adrenal insufficiency that happened following surgery, that was managed, and after 6-month follow-up, patient was settled with all normalization of the parameters. So subtle endocrine disorders, they are associated with adrenal incidentaloma, and they can contribute to hypertension, osteoporosis, and also CV mortalities. And these adrenal incidentalomas, they are found in 5% of the adrenal imaging, with prevalence rising with age, and while most are non-functional, up to 30 to 50%, they can demonstrate subtle cortical autonomy, that is, we call it as MAX. And the third case is a presentation of diabetes patient with severe osteoporosis with fragility fracture. So in this patient, actually the woman who is postmenopausal, having severe hyperglycemia, hypertension, and having back pain, and she was demonstrated to have very low DEXA T-score, and on evaluation, patient also demonstrated to have adrenal incidentaloma, and that is the cause of the fragility fracture. So diagnosis made as the mild autonomous cortisol secretion, that is MAX, with uncontrolled diabetes and osteoporosis. So management, again left adrenalectomy, which has settled all the parameters, clinical complication the patient had. So lesson from this case is that hidden hypercortisolism due to MAX often underdiagnosed in patients with uncontrolled diabetes and unexplained osteoporosis, and it is increasingly detected in patients with adrenal incidentalomas. So the lesson from all these three cases, that means difficult to treat diabetes patient in a setting of maybe hypertension or osteoporosis. So we should suspect this hidden hypercortisolism so that we can land in a diagnosis. So just to document this, I'll discuss three articles, the recently published, among them a recently published. So this is one of the study that has analyzed about 18 studies. So that is among patients with advanced type 2 diabetes mellitus. Advanced type 2 diabetes mellitus means the presence of either microvascular or macrovascular complications, or those who are on insulin treatment, or those who are having hypertension and having on treatment with many antihypertensive treatment and having dyslipidemia. So these are all the cases who are difficult to treat diabetes. So the study conclusion from this case, this article was that advanced or complicated type 2 diabetes mellitus, they had a significantly higher likelihood of harboring hidden hypercortisolism. And the odd ratios were approximately 3.4 and 3.6 in DSL and HK-HJ method of respectively, and dyslipidemia was also examined but showed no consistent association across the studies. And the second article that actually demonstrated what are the clinical presentation. So that has actually seen about 49 case in the series, and the finding from these cases was that about the HID-HICOR, this entity were identified where bone fragility, hypertension, diabetes, and combination of these three were the sole presenting signs, and 34% they had bone fragility, 32% had hypertension only, 6.1 had type 2 diabetes mellitus, and 19% had both hypertension as well as type 2. And 25% of them they were of pituitary origin, and they had bone fragility higher among pituitary hidden hypercortisolism. So lesson from this study is that patient displaying resistant or rapidly deteriorating hypertension, worsening type 2 diabetes, or unexplained bone fragility, they should always undergo such kind of test. And the recent article that has been published recently in the Diabetes Care, that is the Catalyst, the objective in this study to determine how frequently the endogenous hypercortisolism that can contribute to persistently uncontrolled and difficult to treat diabetes despite intensive standard of care. So about 1,057 cases, adults were taken into consideration, having A1C 7.5 to 11.5%. Difficult to treat diabetes patients were those taking more than 3 antidiabetics, taking insulin and other anti-diabetic drugs, taking more than 2 anti-diabetic drugs, plus having more than one microvascular or macrovascular complications, or those who are taking more than 2 anti-diabetics and 2 antihypertensive. So what was the result out of this study? So it was found that hypercortisolism prevalence was about 24% among the participants, that is 1 in 4. They met the criteria for endogenous hypercortisolism. And interestingly, those patients who were taking more than 3 antihypertensive treatment, they had a higher prevalence, that is about 36%. And there are other key findings like the imaging abnormality was found in 34%, and the more cardiac disorders were participant with the hypercortisolism. So there are certain factors were independently associated with the hypercortisolism. One was older age, second was the BMI less than 30, non-Hispanic and the Latino ethnicity, those who were taking SGLT2 inhibitors, GLP-1 receptor analog, more antihypertensive drugs, and those who were taking fibrates and the analgesic. And other key findings that was found in this study was that the unilateral adrenal nodules were present in 22%, 4% had bilateral adrenal hyperplasia, 3.7% are same. And the next step was the part 2. The first one was the part 1 of the study catalyst. The part 2 is the treatment phase, a randomized double-blind placebo-controlled trial, so which will test the role of mifepristone in treating such patients. So what is the lesson from the catalyst 1? Hypercortisolism is very common, that is 24% among type 2 diabetes mellitus who are poorly controlled. Risk is even higher among those having resistant hypertension and CV disease, and screening with overnight DST is very important, and part 2 will demonstrate the treating of cortisol excess, which will improve the outcome. So next is the pathophysiology snapshot. So basically the diabetes that occurs because of the impaired hepatic glucose output, peripheral insulin resistance, adipose tissue redistribution, pancreatic beta cell defect, and other metabolic consequences. These are all the clinical red flags, so you can look for the if there are resistant hypertension, uncontrolled hyperglycemia, disproportionate obesity, central obesity, earlier severe diabetic complications, and osteoporosis or fragility fractures, or depression or fatigue. So these were the situation where you should suspect the presence of a hidden hypercortisolism or subcortical hypercortisolism. So you need to know all these things. Next, what are the diagnostic approaches? So as with all Cushing syndrome, obviously we'll go for at least 1 milligram overnight DST. If it is more than 1.8, so you should go for other tests like elevated late night salivary cortisol, 24 hours urinary free cortisol, plasma ACTH, and adrenal imaging, and whenever it is required, an MRI pituitary gland. So these are like basic investigation that we do in the all Cushing syndrome, all cortisol excess states. So international guidelines, they recommend using at least 2 abnormal tests to increase the diagnostic reliability in such situations. Then what are the management? So obviously when you find out the cause, surgical intervention and medical treatment, they should always be considered wherever it is required. So cortisol source management is always important. Adrenalectomy or transperineal surgery, they are the treatment of choice in adrenal incidentalomas and pituitary Cushing syndrome respectively. Medical therapy in the form of the steroid genesis inhibitor, that is ketoconazole, meteropin, or oscillodrostat, and glucocorticoid receptor antagonist, they may be considered for patients who are poor surgical candidates. And standard of care for the diabetes and blood pressure should always be followed. Post-op metabolic outcomes like glycemic control, BP control, improvement in the osteoporosis, they should always be looked into. And standard osteoporosis treatment like vitamin D and calcium supplement always should be there. And you should consider about the treating with bisphosphonate, denosumab, or teriparatide for severe cases with multiple fractures. And then what are the lessons that we get, and what are the clinical implications of hidden hypercortisolism? So regarding the glycemic control, these patients, they actually require higher doses of antidiabetic medication and also exhibit poor response to conventional therapy. However, adrenalectomy can settle everything. So whenever we come across such situation, like anybody requiring very higher doses of antidiabetics and still exhibiting poor response, so in that case, at least one cortisol will help you in reaching a diagnosis. At least you can go for further injection later on. And cardiovascular release, like they carry an elevated risk of CV events such as MI and stroke. So that is the reason why in such situation, definitely you should go for a cortisol level. And osteoporosis, those who are postmenopausal women or those men more than 50, they present with osteoporosis, a non-traumatic, that is fragility fracture, they are resistant to standard therapy. Sometimes we keep on giving the treatment, but at the end of year, when we go for a DEXA, we don't get the result. And in that situation also, we can, even in osteoporosis also, we go for one cortisol. So because we have to rule out any cause related to hypercortisolism. So in that situation also, we should do that test. And regarding the mortality, the observational studies, they indicate higher all-cause mortality, and there is increased CV mortality among type 2 diabetes patient with subclinical hypercortisolism compared to those without cortisol excess. So the key learning point from my talk is that hidden hypercortisolism is a very clinically relevant entity, especially among type 2 diabetes mellitus and adrenal incidentalomas, and even in the presence of resistant hypertension. They include like a resistant hypertension, unexplained osteopenia, unexplained osteoporosis, fragility fracture, poor glycemic control despite adequate therapy. They require very targeted screening, also multidisciplinary approach. Timely identification may improve the outcome. Screening with overnight DEX suppression test and HCTs, that is very, very essential and critical too. Adrenalectomy and medical therapy or transplantal surgery, they may improve the metabolic outcome. So these are all the key studies and the evidences that I have gone through, and I have prepared this talk. So thank you, ASICON 2025, for your kind attention.
Thank you, ma'am, for the wonderful session. I would request you to please take seat, because we will be taking all the questions after the second session gets over. Thank you. May I now call upon Dr. Sunil Jain, sir. Sir is known to us all a very senior endocrinologist, has taken part in several cardiovascular outcome trials and several book chapters. Sir will discuss on a very relevant topic, that's management of painful diabetic neuropathy. Over to you, sir.
So, thank you very much. I am thankful to ASICON for this opportunity. And see, a few minutes ago we were discussing the diabetes stress, which is coming from central mechanisms, and another very common issue which is creating distress in patients with diabetes is due to these peripheral mechanisms manifesting as diabetes neuropathy, one of the most common issue in our clinical practice. So that's what we know about the neuropathic pain. So what will be my objective of discussion? One slide to know why neuropathy is happening, and the most important thing, why these nerves pain, why the patients are symptomatic, what is the basic logic. We are all using therapies, how these therapies are working, and how we should choose or select among all these available options. That's what I'm going to discuss in this quick presentation. So this is like any microangiopathy plus some association with overnutrition with the neurons and a lot of pathways getting activated, which is finally causing neuronal damage. And now these neuronal damage can happen in multiple ways. Some large fiber disappeared which are responsible for sensory neuropathy and motor neuropathy, but here something happening little differently. Because of these all cascade, the peripheral neurons have got some modifications in terms of those channels which are working over there, and that is responsible for many paresthesia and dysesthesia for which patients are reporting us. So we know that the major concern for patient is dysesthesia, pain, pricking, burning, current-like sensation, somebody is cutting my feet kind of feelings, and that affects their quality of life. We understand that these symptoms are not going to cause any harm. They are not going to cause any muscle weakness or anything like that. But it is the quality of life, and that's how these symptoms are very much disturbing to them. So, why these symptoms? From where this pain originates? So some voltage gated channels which are working at various places we have to understand. So multiple channels are important here. Fourth one was potassium channel, which I have omitted because we are not taking any therapeutics on that area. So some role of calcium channels, sodium channels, and these transient receptor potassium channels, and how these channels are getting involved causing pain. So try to first understand very basic fundamental of pain physiology, that at receptor level some stimulus comes which generates something, that is transduction, which now goes as action potential by the nerves, transmission, which reaches to the dorsal neuron. First neuron ends there. From there the second neuron comes, goes to the dorsal horn. Another neuron crosses the other side and goes to the brain. So transduction, transmission, that happened. But everything reaches to the spinal cord, doesn't reach to the conscious mind. So we have many mechanisms which now modulate these signals which are getting generated at a spinal cord level, not at the neurons. Now I'm talking at a spinal cord level. And then after this modulation, whatever is finally delivered to the conscious brain will be felt as a perception. And this is the basic understanding of all the therapies which we are using to manage our patients with diabetic neuropathy, which is painful. I am talking on painful component of the diabetic neuropathy. So that's what I discussed. A signal generated, reach to the ganglion, then reach to the spinal cord, cross to the other side. We know spinothalamic tracts and through which this is going to reach, but everything doesn't go. There is a lot of filtration happens. A lot of signals are coming from central system to spinal cord also, and they are modulating. And these are the areas where these drugs are going to work, which I will discuss. And that's how finally we are able to provide some relief to our patient. So this is basic fundamental. Multiple things are happening, and that's what is important when you treat your patients and they are not getting enough relief, how to counsel them. So neurons are firing spontaneously. Because of channelopathies, which I talked about these channels, there is a overreaction to mild stimuli. And that's how people say that even a bed sheet moves, I feel pain. We know that is what is allodynia. Inhibitory brakes, that are the modulation system, they are weakened. And these excitatory channels are overstimulated. That's how people are feeling pain. And these are the channels where many drugs are working. If you look, if I talk from the bottom, TRP channels, transient receptor potassium channels, they are located at the nociceptor endings, and there these capsaicin and these local ointments work. They are important, but more important than them are the calcium channels, because they work in the spinal cord level. And I told you the major modulation is happening in the spinal cord. The next area is voltage-gated sodium channels, which are present on the axon. So the transduction part was TRP. Transmission part is voltage-gated channel. And the modulation part will be the most important. That is the voltage-gated calcium channels. They are now located in the dorsal horn. And there, when a signal is coming, then these channels are responsible that this signal is heightened, and that's how, and the modulation coming is also weakened, and that's how patients feel lot of abnormal sensations. And that is what I have used the word here, these channelopathies is responsible. And we know what are the fibers involved for that, which are taking these perception. So how to handle this? Unfortunately, taking care of metabolic control has not helped much. Even the drugs which were oriented towards pathogenesis, pathophysiology of diabetic neuropathy, so many therapeutics, including all these aldose reductase inhibitors and ALA, GLA, benfotiamine, they have not done anything. So what we can do at the most? Do something on these channels, and that's how you can help the patients. And that's how the painful diabetic neuropathy we are managing. And now these are the drugs which we are often using in our clinical practice. This is a bigger list, and let me shorten it by making few drugs bold which we are using most often. I talked about the sodium channels, but as I told you, it is not the transmission. It is the modulation where the big fault is. And that's how earlier we have used this carbamazepine, oxcarbazepine, etc. as a sodium channel. But they have shown less benefit, and that's how the gradually focus moved. And now we have the drugs like duloxetine. It is mainly working on the inhibitory pathway of modulation. The most common and the practically first line therapy used everywhere is the pregabalin gabapentin group of drugs. It is mainly working on the dorsal horn transmission, that is those channels, calcium channels which I was talking about. And then these tricyclic antidepressants have multiple pathways, and that's how these various doses mentioned here. And you can see here, that's what I see generally in practice, that most of the time physicians, doctors, diabetos, they try to keep on a very lower dose. They feel that the patient is not a responder now. Like when you use oral antidiabetic agents, we have no hesitation in increasing the dose. So look at the doses mentioned here, and these are the recommended doses which can be used to manage these issues. And these are the three main drugs: calcium channel alpha 2 delta ligands, which are lying in the dorsal horn where the first primary neuron is ending, and there it's playing a big role, and here pregabalin and gabapentin is working. Serotonin and noradrenaline reuptake inhibitors, these molecules, serotonin and noradrenaline, if we increase in the quantity again in the spinal cord, that section, the pain perception gets modified. And here the duloxetine, venlafaxine group is going to work. While tricyclic antidepressants also work gradually, they are initially serotonin effect. If you increase the dose, the noradrenaline effect also comes. If you increase the dose further, then the antihistaminic and dopaminergic effects also comes. And if you increase the dose further, they become an alpha-1 blocker also. So there are multiple effects with tricyclic. And that's what you can see here in this diagram, that this is the primary neuron ended in the spinal cord, and this is the neuron which will now take the sensation to the next level. And here, when we are using these drugs, like these are the channels where all these molecules, like those drugs, like duloxetine category, they will increase the serotonin and noradrenaline here, and that's how modifying the transmission. And similarly, when we will give pregabalin, it will also reach here, and this will going to modify these sensations. So they are basically alpha 2 delta ligands, which are lying in the spinal cord region, and that's how they are decreasing the substance P release, glutamate release at the synapse level, which is then perceived by the conscious mind. Duloxetine is increasing the synaptic availability for serotonin and noradrenaline, and that's how the pain modulation is happening, while TCA is working by multiple ways. Initially, it is also having work on the same serotonin pathway. And these are the recommendations, like this is the ADA recommendation, which talks about the gabapentin and pregabalin group, then the SNRIs, that is duloxetine groups, sodium channel blockers, etc. This is the 2011 recommendation on management of painful neuropathy, that looking, you can based on certain criteria which I'll just quickly present with you, that you can start with one of the three drugs which we discussed, pregabalin group, duloxetine group, or tricyclic antidepressant group, and then keep combining. Preferably use the combination of two rather than three. That will be preferred, because if you combine all the three, that two in a higher doses, then more serotonin in the spinal cord level can cause serotonin syndrome. Doses we know, and there are few things, so which drug to select? And these are the patient characteristics. Because if you try to look at the mode of the action, most of the drugs are working through more or less similar pathway in the spinal cord. Somebody has depression because duloxetine is working on SNRI pathway predominantly, and that's how it will work as an antidepressant also. Pregabalin also causes NPY release from hypothalamus, and by that it increases appetite, and that's how pregabalin is known to cause obesity. Generalized anxiety disorder can be considered. Sleep disturbances all work. Any person with a cardiac issue because of anticholinergic effects of TCAs, preferably they should be avoided, and same reason for autonomic neuropathy also. And just remember, duloxetine is contraindicated in hepatic failure and renal failure, and elderly patient, obviously we have to be cautious because of many issues for TCA. So that's how we can tailor the treatment plan. And in a patient with CKD, your preference should be pregabalin, that too with a dose adjustment, and tricyclic antidepressant, and preferably avoid duloxetine, and rest of the things I have already mentioned. So for painful distal symmetrical neuropathy, my take-home messages will be, it's one of the most common symptom of diabetes. The diabetes specific symptom, if you will take, the most common will be pain in neuropathy, which is present irrespective of duration of diabetes. None of the available treatment is solving the problem. They are just for symptomatic relief. In spite of the best possible treatment, 60% patient only respond well, and that's why there is a lot of need of patient counseling. Though we have drugs, the three major groups I talked, but good if we right from the beginning can set the right expectation for the patient, that if you get this much relief, if you are getting a good quality of sleep, be happy. If you can do this much, that will be a good approach to manage this painful diabetic neuropathy. Thank you very much.
Thanks a lot to both the senior mentors for insightful talks, right from pathophysiology to management. The house is open for questions.
My question is for Jain sir. Sir, the problem is that when we use this medicine, pregabalin, gabapentin, for suppose 2 months, 3 months, and after that we taper down or stop the dose, patient generally again comes with the same complaint. So how to proceed further?
So that's what you will see in the natural history of painful diabetic neuropathy, that 2 months, 3 months is a too short time. It will go longer. Now what is happening? The remaining neuropathic processes are going on, and finally over a period of time you will see that many such patients, pain part, dysesthesia part gradually disappear, and it is replaced by numbness and the loss of sensation, and now they start talking more on the large fiber neuropathy component as well. So if you reduce the dose, that means the spinal cord issue is still going on, you have to continue the therapy.
So how long we can continue, sir?
There is no upper duration. You can carry on for an indefinite period. They are symptomatic.
So Dr. Jain, just one comment, you can take it as a question. One of the adverse effects with pregabalin and gabapentin is pedal edema. It can occur, I think, around, for gabapentin is 8 to 12%, pregabalin up to 15%. I could not get any good data to suggest, therefore, that are they a contraindication for patients with heart failure, therefore. Pedal edema is important because many of the patients are on amlodipine and will blame that, but that might be one of the causes.
So yes, pedal edema is known with pregabalin gabapentin group, and as I explained you the mechanism, they are working on the calcium channels. So when they are working on these alpha 2 delta receptor calcium channels in the neurons, not directly in the vasculature, this is going to finally cause vasodilatation. And this vasodilatation will increase the capillary pressure, and that leads to edema. And this edema is actually a fluid retention. Now it will depend on case to case. So somebody in whom, because of heart failure with reduced ejection fraction, a small fluid, because fluid retention you will see it is not going to happen in all patients, in a small subset, and obviously in a patient with HF it will be difficult to differentiate the contribution of the pregabalin or gabapentin component. But yes, wherever a small fluid retention is detrimental, though obviously these patients will be managed with SGLT2 inhibitors also, diuretics also, and if the patient is edema free, fine, then we can continue. Otherwise, though it's not a contraindication, but it will be a relative consideration to avoid in such situations. But yes, and there is a mechanism which is well known for pregabalin induced pedal edema.
Actually, you should have to weigh both the situations. Heart failure is one side and the painful edema is the other side. So if you adequately treat the heart failure, and if it is well controlled, giving to the patient, we can titrate the dose.
That's what I'm telling.
Which direction we treat the patient, and you shall have to individualize. There is no clear-cut guidelines in this.
No, there can't be any guideline here. It has to be obviously a patient-based decision at that particular point of time, but it won't create a very big issue in most of the patients. That's what I want to convey.
You have mentioned that the dose of the pregabalin maximum to the tune of 3,600.
Gabapentin. Because the gabapentin absorption is saturable. As you are increasing the dose of gabapentin, its absorption is decreasing. It is not happening in a linear way. While pregabalin gets absorbed linear way 90%. So there is a huge difference in the pharmacokinetics of these two molecules.
Do you hit hard at the beginning, or do you escalate the dose gradually?
Always escalate those gradually because they are all working on central mechanisms. They are going to cause a lot of side effects, dizziness, sedation, and so many things. So always gradually escalate and look into the patient tolerance, you should manage it. That's always, I see that, and I don't know, but it is very common that a typical diabetic neuropathy patient coming to me via a neurology consultation, all the three drugs are generally mentioned in a good doses. Anyway, I hope that since they are very well versed with all these molecules, so they are more using in a larger quantity right from the beginning.
Sir, please.
But gradual increase is always preferable.
Commercially available, all drugs practically are having nortriptyline with that, pregabalin and nortriptyline. How is the combination and how it scores over amitriptyline?
How is the?
Scores over amitriptyline.
Oh, see, the amitriptyline finally gets converted into liver to nortriptyline. This is one thing. Now, once it becomes nortriptyline, its effect is more on serotonin pathway rather than a anticholinergic effect. So the anticholinergic effect is more stronger with amitriptyline versus nortriptyline, though both carries. That is the difference. And that's how, if your objective is mainly to take care of depression, sleep, more of pain, fibromyalgia, etc., you can consider amitriptyline, right? And patient does not have any cardiac issue, etc. In general, for cardiac issue, both the molecules are not good. But if at all you are forced to consider, then nortriptyline will have less anticholinergic effect than amitriptyline. That's how these two molecules differ.
In combination it is.
Yeah, combination. Again, same way. Finally, somebody to start with, everybody with a combination will not be a good idea. You can start with first one of the two, maybe pregabalin. If required, you can add the second one.
An antibody. So, what is your opinion?
I did not see
many of the combinations contain this ALA.
Most of the combinations which are containing pregabalin in India have 100 milligram of ALA, and 1500 microgram of vitamin B12 and many other things. And this is basically a subtherapeutic placebo-like dose of ALA.
We from Endocrine Society, you should tell something to these manufacturers.
I feel that like the original manufacturer did not market it as a combination. The Lyrica was just pregabalin.
So I'll have the last question. Sir, when to refer a patient to a neurologist? Because sometimes this painful neuropathy is very, very distressing.
So rather than neurologist, the next level will be either pain clinic, because they can manage it better. And see, there are few things which I have never tried because I am not the expert of that area. That is the IV lignocaine, 5 milligram per kg IV. Obviously, you will require a cardiac monitoring and everything. But otherwise, better than that, the idea will be there are experts now who will handle it. So let them.
Just one query to ma'am. The Catalyst trial has opened a Pandora box, ma'am. And if we see, most of our patients will fall into that bracket of difficult to treat diabetes. Like they have mentioned just 3 drugs. Most of our patients are metformin, sulfonylurea, DPP-4, SGLT2. Already 4 we have crossed. So how to go about it? So should we evaluate all our patients?
Difficult means those patients who are taking more than 3 antidiabetics and insulin maximum dose, tirzepatide or whatever drug, then only you will suspect, no?
Thank you, ma'am. I'll discuss.
Okay, you are doing so many tests. Just one more test.
So with that, we have come to the end of our today's session at this hall. Thank you, sir. Thank you, ma'am, for the wonderful discussion. Thank you, all the delegates present here for the wonderful interactive session. With that, we have come to the last of our session today. Thanks for your hearing. So we'll proceed to the valedictory session and the award ceremony.